Hello and good morning. I think I need to start this. I love that song, Where is the Love? And I think that it's very fitting for what we're doing. Just a reminder, I'm Angela Mensa, and I'm one of the last presenters on the meeting today, but I tried to help as much as I could to get things together for us. We are in meeting mode, so you are welcome to turn your cameras on for our sessions. We'd love to see your faces, but if you don't want to have that camera on, that's okay too. I am going to introduce our wonderful moderator. Her name is Bethany Verbregi. She is a neurodivergent and LGBTQ plus affirming EMDR certified therapist. She received her master's degree in social work from the University of Michigan. Go Michigander. She received but she also provides therapy services in Atlanta, Georgia. They're in English, Portuguese, and Spanish. She utilizes EMDR, sand tray, play therapy, and attachment and somatic focus strategies to empower her clients. She specializes in working on trauma and has also completed advanced training in treating eating disorders. She has a wide range of experience working with clients with a variety of presentations, including borderline personality disorder, depression, anxiety, emotional dysregulation, suicidal ideation, and self harm. And more. We want to welcome you, Bethany. Thank you so much for being here.
Thank you so much. I really appreciate your wonderful introduction. And so what I'm going to do now is kind of go through the bios of the people who will be presenting today. So hold your horses and get ready. We'll start with Dr. Angela. So Dr. Angela holds a PhD in communication studies from Bowling Green State University and is an accomplished educator, scholar, and advocate for diversity and inclusion, currently serving as an assistant teaching professor in the Department of Communication at the University of Arkansas, Fayetteville. Dr. Mensa holds a PhD in communication studies from Bowling Green State University. With over 20 years of teaching experience, she specializes in media literacy, body image, and communication. Dr. Mensa has been recognized for her innovative teaching methods and commitment to social justice. Notably, she earned her National Communication Association Social Justice Division Pedagogy Award. Dr. Mensa's work reflects a deep commitment to bridging academia and community, empowering students and audiences to engage with media representation and societal narratives critically. Thank you so much for being here, Dr. Angela.
Thank you for having me.
All right, and so next one, and you know what? I didn't go over how to say you guys' names. So um we've got Ines Pani, maybe. Ines began her 46-year nursing career in 1977 at Truman Medical Center, historically the segregated General Hospital Number 1 and Number 2, until they merged as Truman Medical Center in 1976. General Hospital Number 2 served Kansas City's African American population, especially the poor. As a teaching hospital affiliated with the University of Missouri School of Medicine, Truman provided a rich environment for Ines to build comprehensive nursing knowledge, skills, and expertise. Nursing becomes more than a passion. She describes nursing as her mission field. Thank you so much for being here. Um, Going on, we've got Joan Zhang. Joan is the co-founder and CEO of Arise, whose vision is to create a world where everyone, everywhere, has the freedom to heal from eating disorders and disordered eating. Joan brings her own lived experience with eating disorders and mental health conditions, alongside a deep empathy for the diversity of the mental health journeys of so many others, to drive her work as a product leader in the mental health tech space. Before starting Arise, Joan was a product leader at Headspace Health, where she led initiatives that empowered members to get into clinical care faster than ever before and led personalization initiatives. Joan holds a BA cum laude in psychology with a minor in computer science from Harvard College, where she conducted fMRI research to understand how stress impacts our ability to utilize cognitive reappraisal, and also published a book on the mental health experiences of Asian American students at Harvard. Thank you so much for being here. Next, we have Dr. Erica Taylor, MD. Erica is a board double board certified child and adolescent psychiatrist with over 15 years of specialized experience in eating disorders and mental health. She is the chief medical officer at Arise, a virtual program dedicated to eating disorders treatment, and serves as a board director at Project Heal, a renowned nonprofit committed to dismantling systemic barriers and providing comprehensive support and education to individuals from diverse backgrounds grappling with eating disorders. In addition to her leadership roles, Dr. Taylor is a partner at Catalyst Therapeutic Services, a private practice in Durham, North Carolina. Furthermore, she serves as a consulting associate at Duke University Medical Center, where her expertise significantly contributes to advancing psychiatric care. A passionate advocate for mental health, Dr. Taylor participates in the DSM-5 committee of the APA Race, Ethnicity, and Equity Committee of the North Carolina Psychiatric Association. She has served as the past president of the North Carolina Council of Child and Adolescent Psychiatry. Dr. Taylor's academic journey includes a Bachelor of Science degree from Spelman College, a Master of Public Health in Healthcare and Leadership from UNC Chapel Hill, and a Doctor of Medicine from Duke University School of Medicine. Additionally, she holds a certification as a yoga instructor, further integrating holistic approaches into her practice. Thank you so much for being here. Next, we have Dr. Leslie Williams. Leslie is a board-certified family medicine physician and eating disorders expert. She received her medical degree from the University of Kentucky College of Medicine and completed her family medicine residency at Mayo Clinic, Arizona. Dr. Williams has given national and international lectures on various topics relating to eating disorders and is recognized as a clinician leader in the field. Dr. Williams serves on the Academy for Eating Disorders Executive Board of Directors. Her professional passions include midlife care for women, health equity advocacy, and weight inclusivity education. She is the award-winning author of the children's book, Free to Be Me, Self-Love for All Sizes, and a contributing author to How to Nourish Yourself Through an Eating Disorder. Her clinical practice encompasses full-spectrum primary care for all ages. Dr. Williams enjoys helping patients strive for well-being regardless of their medical conditions. Her clinical focus areas include eating disorders, well-being promotion, integrated mental and physical health, weight-inclusive care, healthy aging, midlife health, and menopause. In addition to her clinical activities, Dr. Williams is active in research and education. She provides educational content on topics including midlife eating and body image, work-life integration, and weight stigma prevention in healthcare. Thank you so much for being here. And then last but certainly not least, we have Mimosa Collins. Mimosa obtained her Bachelor of Science in Dietetics from the University of Vermont and graduated with honors as a result of her research in food and culture. She is a registered dietitian and founder of Rejoin Wholeness, a virtual private practice committed to equitable, accessible, and client-centered nutrition care. With over a decade of experience in the field, she has over 2,500 hours working extensively with individuals and families facing eating disorders, including 3 years working as a lead dietitian in the partial hospitalized and intensive outpatient levels of care. Mimosa completed her Level 1 training in internal family systems therapy in 2020 and continues honing her craft through supervision and serving over 150 hours as a program assistant to BIPOC Affinity Level 1 training groups over the years. Mimosa began her career as a dietitian in community mental health and interned at farms throughout the country to learn about food systems from the source. These early years in public health laid the foundation for her dedication to disrupting oppressive practices in her professional and private life. With this intention, she has worked with psychodramatist Leticia Nito since 2019 and is part of the Eating Disorder Harm Reduction Providers Network, facilitated by Gloria Lucas of Nagola Positivity Pride. Her passion for client-centered care as liberatory care has been shared through regional conferences, workshops, and mentorship. Through her work, Mimosa continues to challenge traditional models of treatment by illuminating power imbalance in eating disorder recovery and disrupting that imbalance one client at a time. Thank you so much for being here.
And
Bethany,
Bethany, last but not least, indeed,
there's one
Jean.
more last but not least, which
Jean.
I can introduce myself.
I don't think I have your bio, but if you want to send it to me really quick, I can read it for you.
I think it would just basic and simple. I can just say that I'm
I'm so sorry.
no, don't be. It was just funny.
I was thinking about it too as I was saying it out loud. I was like, I think we're missing at least one person. But since I didn't have the bio, I was like, maybe I read it and I just spaced out for the whole bio. So, okay, thank you for
Oh,
jumping
no,
in.
not at all. And I'm Jean Catanzaro. I'm a clinical psychologist. I am co-leader of the IFS Institute, and I have been working in the field of eating disorders and trauma since the mid 90s. And I trained originally in psychodynamic psychotherapy and then went on to train in EMDR and somatic experiencing, and that before discovering the internal family systems model. And this has been the work that's been the most transformative for me and my clients, personally and professionally. And I am increasingly focused on and have been with the Institute on making our IFS more accessible to people. And I'm looking forward to speaking about what that means to me. And just being able to be a part of this day-long conference has felt so important. I'm really excited for the content. I think there's a lot of work that we need to do within IFS, of course, and broader, but to be able to make our work more and more healing, available for healing, especially in this field of eating disorders, which has been notoriously narrow and discriminatory. And I should add that about 22 years ago, I was the director of a day treatment program in eating disorders at the Renfrew Center of New York, and spent a good many years getting to know the different treatment centers in the country. And so what really shifted my focus was discovering IFS. And Enos and I know each other from this time where I started referring my clients to a treatment center that centered IFS work as the primary modality. And just to really, really notice that all of the approaches I had learned were and are valuable, but this one was really the key for a lot of transformation. And it feels like the key to transforming the larger systems that keep so many people oppressed. And so I am really looking forward to this and appreciate meeting the folks on this panel, and look forward to today. So that wasn't so short, but it was from the heart. And I guess let's get going, right?
It was beautiful. It was meant to
Thank
be.
you. Thank you.
Jean and Eunice, do the two of you want to take it from here?
Sure.
I
Sure.
think Mimosa was going to
Oh,
give some community
I
guidelines.
think we all were, right? I think, or a number of us were gonna. You want to start, Mimosa? Or I
Sure,
can
yeah.
start. Whatever.
I can jump in. First of all, thank you to everyone who chose to be in this group today. It's this work is work. It's labor. And part of the part of the labor that is involved with our presentation today that I just want to call in and invite us all to be intentionally with is that we are going to be centering the experience of groups that are normally on the margins. And for those of us who are here today who might hold privileged identities, part of having a privileged identity is having your experience in the center. And when we flip it, and the people who normally have their experience in the center are not in the center, like we'll be doing in this day, at least for my talk, that can activate some of our parts that might have feelings about what is risked when we're not in the center, what safety is compromised when we're not in the center. And I think that one of the values of doing work like this is to notice, identify those parts within us, and to do the work of building relationship with those parts so that when we're out in the world, we can be self-led and not led by those parts that hold fear about what happens when we're not the primary focus of a movement or a conversation or an action that's being called to happen.
Mhm.
So that's the first invitation that I would like to extend to everyone here today.
Mhm.
I apologize, my mic wasn't on before I tried to transition us, but I did notice that Dr. Leslie is here, and so I wanted to acknowledge that because she will, well, I wanna make sure she starts promptly at 5, but Jean,
Okay.
you talked about how, us we can't make this safe space, but you talked about a brave space. Can you help us understand that?
Well, I'm just learning from so many other people who have really helped me understand that difference where, the idea is not for us to, kind of following what Mimosa was saying. The idea for us today and increasingly, hopefully, in all the spaces we're in, is to not center our own comfort and to really like look to be taken care of and kind of everybody's going to be okay and not activated, but instead to create spaces where we can be attentive to what's coming up for us. And the IFS model gives us a really great way to do that is noticing our own experience, our own parts who are welcome inside of us, and giving them the support that they need to be able to relax back, to be present, and both receive and contribute in a way that is a supportive as much as possible for others. And I think, we can't guarantee safety for anybody, right? Safety is relative. And so really checking inside and seeing what do my parts need. And it may mean that you hear things today that actually shake your assumptions, that make you a little uncomfortable, angry, whatever it is, and just all are welcome inside your system and just seeing what you can do to notice them and notice them and be with them in whatever way they need. And so that you can actually take the risks, have the courage to be curious about things that feel foreign, the courage to try on new things and that test maybe make you feel some type of way about ways you've thought of things or treated other people in the past. So that actually, whether or not, because I'm assuming a number of people will see this recording later. So we're contributing each of us to a collective space here that hopefully supports a lot of new learning and reception. But in the moving forward, we're also doing that for others we're going to invite others who are watching it to do the same sort of checking in with what do parts of me need, whether it's a break for a moment, come back, listen again, talk to somebody, but whatever it is that can increase a little bit more of a holding this material in a different way.
And
I
one
guess I'd
thing
also
I
like to just add that probably a reason we're saying what we're saying right now is that this is not necessarily a subject matter that really gets an arena in many places, especially at a conference about eating disorders. So there's just a level of vulnerability in what's going to be presented across the table over the next several hours. And we're just inviting everyone, the panelists, each of us and each of you who've chosen to come and participate with us to just recognize that we're doing something kind of courageous, brave, and bringing a lot of curiosity to understanding, uh, just understanding one another better.
Mhm. Mhm.
Okay. And one thing I always like to mention to my students, I teach a gender, race, and power class. And things that often come up for me in my classes, I explain the ways in which, sometimes America gets a bad rap. I'm sure people on this call have hopefully read the book No Mud, No Lotus. Our mud is a history that's entrenched in a lot of trauma. Our lotus is what we have today and all the comforts that we have today. Yes, those comforts have been afforded by people that might look like me, and I also explained that Americans are not the only countries that oppress people, that enslave people, that mistreat people. So let's get that out of the way and understand that that is a human condition. People in other parts of the world that have the same skin complexion do the same thing that to people that look like them. So we have to understand that. And also, I try to have my students really think about the ways in which they've been oppressed in their lives from their own identity location. And I have them journal that. And I also explain the ways in which that I, as a heterosexual woman who grew up in a very religious household, a very conservative type of household, that looked at people that were gay, lesbian, or bisexual in certain ways. And I came out into the world and into college very much anti LGBTQ until I met people and befriended people and wouldn't have a PhD without people with other identities if I had not opened up and had relationships with and to those people. And then what I do even today to continue to check my own biases and to learn how to have empathy with them. And something Enos said last year was like, you have to mourn with us before you can actually understand and be able to support us and lift us up. And so what I do is I think of the ways in which that I'm oppressed and try to empathize with people, for example, in the transgender community, something that years ago that I would have been like, absolutely not. But then when I realized how my body, as a fat Black woman, has been oppressed and has said, you have to look like this and you have to fit this and you have to be this narrative, and say, no, if I don't want it for me, then why would I want it for someone else? So I continually reach back to look at my own experience to try to kind of bridge that gap of knowledge, to be able to have empathy with communities that are not like me. And I invite my students to do the same. And throughout the semester, I really feel like, my students have grown. Unfortunately, that class might not be offered again, but I feel like, we really made an impact the times that I've been able to do that. And I'm inviting everyone to do the same thing here. Really think about it. There's no one in here that hasn't been touched by oppression. So at least we can start at that base level and try to have empathy with folks that are not like us. And I would, if does anyone wanted to add anything before Dr. Leslie started? Okay. Nancy, will you be sharing Dr. Leslie's slides, or does she need to share her own slides?
I believe she's planning to share her own. If that's different, please let me know and I can pull them up very quickly.
And Dr. Leslie, just so you know, we plan to have our cameras off so you'll be centered. And so remember to turn your mics off if you haven't already, and I will turn mine off.
Okay, can you guys see and hear me?
Yes, ma'am.
Fantastic, but unfortunately it went back a slide that I didn't want it to do. So I apologize that it doesn't have my initial slides up. Good morning, everybody. Thank you so much for that introduction and just this opportunity to just be vulnerable. I really appreciate that invitation. And in full transparency, that is not my comfortable space. I am a physician, medical doctor. I work more in the objective spaces. And so sometimes when I am asked to give a talk that requires me to tap into some of my own vulnerabilities, it can be a little bit more challenging. It's not necessarily my comfort zone, but I really am appreciative of the opportunity to bring not only my professional experience, but my personal experience to this talk that we're going to have today. And much of the conversation is really around the idea of stigma and how stigma, particularly within the medical community, can play a role in the development and the maintenance of an eating disorder. And I think this is a great kind of segue into the work that you guys are going to be doing later on today, looking at IFS, because a lot of what we're going to talk about related to stigmas, particularly in underrepresented groups, is steeped in that IFS model. And so just a little bit about my background. As I stated, I am a family medicine physician and eating disorder specialist. I currently work at Mayo Clinic in Arizona. My primary practice is providing primary care to a slew of different people. And I also have a subspecialty clinic where I specifically work with patients who have medical complications related to eating disorders. I've been doing this work now. I did the math, but it's been a very, very long time. Straight out of residency, I went straight into working at an inpatient eating disorder treatment center and was there for over 10 years. And from that, have continued to do this work and an active member of the Academy for Eating Disorders. So just wanted to give a little bit of background from my professional or academic lens, what brings me to this space. And then I'm often asked the question of why eating disorders? What kind of sparked your interest in eating disorders to begin with? And I think much of that is steeped in my own personal experience. When I think about my own family system, my mother grew up in a family that was very large. And in their community, they lived in a small, somewhat insulated, primarily Black community within rural Kentucky. And it was overall lower economic status. And one sign of wealth was being able to have adequate food for your family to eat. And my mother's family was wealthy in that she had two working parents. They had access to whatever they wanted in terms of food, and that was a new experience for Blacks in the South who hadn't always had that type of access. And so food was an opportunity for community. It was an opportunity to just gather. And for them, in a lot of ways, my mom describes how it was a reflection of their affluence. And so they ate and would eat heartily quite a bit. And she then struggled with even the weight stigma within their own community because her family was then larger in size, and there was some stigma that went along with that. And from that, there were some medical complications that family members struggled with. And my mother, from a very early age, had it ingrained in her brain that to be larger is the worst thing in the world. It will result in stigma and potentially death. And you need to protect yourself against that at all odds. And so she kind of grew up with that lens and then went on to try and raise her children with that same kind of foundation. And so I just can recall from a young age being so puzzled because I didn't grow up necessarily where my mother was very open about these emotions or her family history. It's only been since I've become an adult that we've had some of these open conversations. But I just recall her being so hyper focused on food and weight and size. And it was just, it felt like, in my mind, like this colossal waste of energy. Like I just felt like if we were able to focus on something else, that life would be so much richer, right? There was just so much time focused on this one area. And then as I evolved, I started learning more about eating disorders and recognize some of those behaviors being similar to what I had seen kind of in my own family or in other people that I knew, but it was something that was completely taboo within our culture. Like that is not something that anyone would have ever labeled. It just was something that was a foreign concept. And even when I think about eating disorders, I feel like my first introduction was through like, what do they call them? After school specials, where they would teach you about, little snippets about a story and a mental health concern. And I remember seeing those images, but never seeing anyone that looked like me. And so a lot of my interest or, predisposition to do this work was just around some of those foundational issues that I recall from a very young age. And it wasn't really until I got older that my mom started opening up about, some of the really traumatic experiences that she had had around like weight stigma, the medical community, and how that had played a role in some of her kind of thinking process. And one of the things that really struck me that my mom hadn't told me until later was that my grandmother was actually one of the first women in the state of Kentucky to receive a gastric bypass, like back when I think it's like in the early 70s or something, when they first started doing gastric bypass surgeries. And again, it was this idea, there was a older Black woman, she was heavy, and we need to make her smaller at all costs. And she had one of the early gastric bypass surgeries that was, just terribly unsuccessful. Like she lost an extraordinary amount of weight, could not eat anything. They ultimately had to go in and reverse the surgery. And I just recall as my mother told me that, and my mother was so traumatized by that, the idea that her size had been pathologized for so long, and then they were willing to make this radical change. And that was really what started all of her medical complications as a result of that, and the lack of trust in the medical community that they were willing to do this radical surgery on this woman who really had minimal education, did not understand what she was getting into. And it definitely felt to the family like an experimental type of situation, which is a lot of the fears around people of color and their interactions with the medical community are steeped in this feeling of not feeling safe and not feeling properly regarded and potentially being experimented on type of a thing. So that is just a little bit of an introduction into me, my professional experience, what brought me into eating disorders, and how that really overlaps with our conversation today about medical stigma and the role that it can play in the development and maintenance of an eating disorder. So as we review our objectives, our first objective is just to understand that, to really have some understanding about how that plays a role, to recognize the importance for culturally competent care for us to really be able to meet the needs of our patients from marginalized groups, and to kind of open up an invitation for each of us to reflect on what we can do in our own spaces to help improve that care for people that are coming from a marginalized experience. And I'm sorry. So why me? I kind of just answered that question in that I bring to the table my professional as well as my personal experience with this subject matter. And so, as we've kind of touched upon, stigma in healthcare really contributes to eating disorder development and persistence. And the way it often shows up really is in weight stigma. I find oftentimes is that within the medical community, there has been this constant narrative that to be at a larger size is a death sentence, and that it is not possible to be at a larger size and to be healthy, and that we need to do everything within our power, even if it means doing something unhealthy, to try and make our bodies smaller. And so that constant messaging that has been there within the medical community really puts patients that come from various backgrounds, various sizes in a conundrum, because I maybe don't want to interact with a healthcare professional due to fear of what they may say about my body. I am in a larger body size and I'm living a healthy lifestyle, and I am uncomfortable with some of the comments that are made or things that are put in my chart. I feel somewhat helpless regarding how I can advocate for myself within medical spaces, because I feel oftentimes disregarded because maybe my cultural background, my size, whatever the case may be, that I'm not being kind of put first in terms of the goals for my overall health. So I hear a lot of these stories from my patients, and I just find that the end result is that people are less likely to go to the doctor, that they are less likely to advocate for themselves, and that they are less likely to get the tools that they need to live life to the fullest and be the healthiest that they can be. And one of the ways that this really was illustrated for me was right after the pandemic. I felt like I had read a lot about patients avoiding interactions with the medical community because of fear of size and weight gain, but it was very prevalent right after the pandemic because, as we can all recall, many of us were on shutdown, we were stuck in our homes, we weren't as active. And so I think the average American probably gained a few pounds during that very kind of globally traumatic experience. And oftentimes, when patients were kind of starting to come back into the office and schedule their GMEs, people who had never really had a concern about their bodies or their weight or anything would frequently tell me, I knew it was time for me to come in for my physical, but I had gained a few pounds and I was just so afraid of what someone might say or what would happen. And so I just have been putting it off. And I was like, wow, that really kind of struck a chord with me and kind of illustrated thinking of all the people who never come in at all because of that same fear. And so it really provided an opportunity for me to chat with my patients about, hey, we all just lived through a globally traumatic experience. Whatever you needed to do to survive that, who cares if it also involved gaining a few pounds? Like, we're here now to kind of like reset and together start, working towards your health goals. And just the relief that patients felt with not feeling like they were going to be judged. But it also just really illustrated to me is how much patients oftentimes feel judgment within the medical community. And we know that underrepresented groups that are living in larger bodies have kind of that dual layered feeling of stigma, is that already I'm feeling uncomfortable, I'm feeling not as safe within medical communities because maybe what my family has told me or what I've read about in terms of historical perspective with not being centered within the medical community. And then now I'm also in a larger body. So there's like this duality to the stigma that I'm feeling. And so definitely those groups being more vulnerable to weight stigma within healthcare. And then oftentimes, just frank avoidance of interaction with healthcare altogether. So when we talk about medical stigma, it's important to recognize that it comes in a variety of different forms. Much of our conversation today will be particularly around the idea of weight bias and racial and ethnic bias, but there's gender biases, there's all kinds of biases that we can see within the medical community. And oftentimes this contributes to eating disorder risk, right? So if someone feels as though their body is at a larger size, or maybe just there's someone that's coming from an underrepresented group that's living in a community of people that don't look like them. And I can't necessarily change the color of my skin, but what I can try to change is my body shape or size to try and fit in with the mainstream culture. And so we know that that stigma can lead to kind of starting to experiment with or be at risk for disordered eating or eating disorders, and particularly women of color, particularly those in larger bodies, really struggle with those overlapping biases. And I think it's important to recognize that this often leads to barriers in diagnosis. So we know that there's tons of research to support the fact that underrepresented individuals are often misdiagnosed or not screened, that in the medical community in particular, we're very quick to tell someone, you know, for instance, if there's been a radical shift in their weight has gone up rapidly. Typically, you know, the knee-jerk response from the medical community is to chastise that person, to tell them they need to lose weight, to give them all of the potential risks of being at a larger weight. And on the flip side of that, if there's a rapid weight loss, the knee-jerk response is to congratulate them and tell them how wonderful they're doing. When in actuality, anytime we see those rapid shifts, really we should be focused on what's changed here, what's going on. And that's a great opportunity to kind of ask the question about what kind of behaviors they're engaging in, their relationship with food and their body. And that's really an opportunity for screening. Excuse me. But what I found, particularly in the medical community, is that we're more apt to screen if someone has a very, very rapid weight loss and they're considered in the underweight category, but less likely to screen when we see those other risk factors such as weight fluctuations, changes in mood, if someone is at a higher or what's considered an average weight. And so, hopefully one of the take-home points from this conversation is recognizing that eating disorders come in all different shapes and sizes, and it is very infrequently, as you all know, working in the eating disorder community, that someone comes in with a placard saying, I'm here to talk about my eating disorder, right? And so just having those opportunities to open up conversation and talk about this regardless of the patient's background is one of the hopeful take-home points from this conversation. And so in terms of weight, stigma, and body dissatisfaction, we know that being stigmatized due to your weight, and it doesn't often always have to come from the medical community. It can come from your own family, it can come from schools, it can come from work, regardless of the source. We know that weight stigma can lead to internalized shame and disordered eating. And oftentimes some of the mood disturbance that goes along with that feeling poorly about yourself leads to further disordered eating, potentially in the form of binge eating, is what I often see. And we know that medical settings often reinforce some of these harmful kind of weight-based messages. For instance, it's still pretty much commonplace in the medical community to have a scale that is right in the middle of a busy, you know, kind of corridor, if you will, of the medical practice, where people have to be weighed publicly. And there's just potentially a lot of shame surrounding that. And that leads to a lot of this disordered eating that we see. And we mentioned some of the distrust in healthcare. Oftentimes people from marginalized communities are not going to be as forthcoming. They're not going to be as eager to come in and get their routine healthcare screening and so forth. And they may not be as forthcoming regarding these behaviors. And that's where I feel like that culturally competent care is so important. I'm very fortunate because I do come from a marginalized background, that I feel like patients are willing at times to open up to me where they may not have in other arenas. So I definitely have that that fortune in terms of being able to come at that lens. But I think all of us have that ability, once we build a rapport with patients and let them know that they're in a safe space, for them to kind of open up and talk about, you know, what they're really struggling with. And we know that discrimination and past harms that have happened within the medical community have fostered that mistrust. And so I think it's important for us to recognize that. And it's not a myth or a misconception. It's a truth. There's plenty of, you know, documentation to support the fact that that has happened. And so to recognize that with our patients, and you know, to not dismiss some of their trepidation. And as we stated, they will oftentimes avoid care. And so I find that with my patients from marginalized groups, they often have lots of competing interests that they're dealing with, particularly my Black women, that they're being caregivers for their family members, you know, being children, as well as, you know, aging parents, that they may have multiple hats that they're wearing, and that their own health often goes by the wayside. And so when they do take that opportunity to come in for an appointment, I don't really kind of get on them for the fact that they've missed two prior to this one. It's like, congratulating them for coming in, for taking the time. And always I acknowledge all the many hats that they wear and say, hey, I know that you're doing all this hard work in terms of caring for your family. And we need to recognize that you maintaining your health is important for you to continue to wear all those hats that are so important to you. And so you and I in this space are really going to focus on how we can help you live your healthiest life so you can continue doing all that great work for your family that you really, really enjoy. So another thing that's important for us to call out is that there's been limited representation in medical care, particularly in eating disorder care. We know that eating disorder treatment centers are often the eating disorder treatment research and the centers themselves are often very narrow in terms of their focus. And, there's concerns about a lot of the changes that have been happening currently in our political climate in an effort to that might make those gaps even wider in terms of getting adequate access to care, but also getting research that we know that's inclusive, because we recognize that, one mode of treatment might not work the same for every single group. And so we want to be flexible in our approaches to how we're delivering care, and recognizing that we sometimes have to meet people where they're at. I mentioned when I was talking about my background, straight out of residency, I went in to do inpatient treatment, which at an inpatient treatment center. And at that time, I thought, wow, I'm seeing the sickest of the sick patients. Like, these patients are really, really sick. These patients are really, really in need of my help. And I love the work that I did. But it was interesting when I then transitioned later to doing outpatient work that I really had my eyes open to how many people are out there struggling who never, ever make it to getting access to that level of care, right? That level of care is truly limited to those that are quite privileged. You have to have insurance, you have to have good insurance, you have to have the money to pay for the copays, you have to have the ability to take time off of work. There are a lot of things that are required for you to be able to have access to that level of care, and recognize that there are so many people out there in the world that are struggling that don't have even one of those things that are needed to get that level of care. So that was very, very eye-opening for me, and even further kind of accelerated my passion for wanting to help people from all different backgrounds, and recognizing that our answer to every issue in terms of disordered eating can't be they need to go to treatment, because that isn't a reality for some people. So, in terms of case examples, as I was preparing for this talk, I'll be honest, it was at a challenging time emotionally. There's a lot going on politically in this country, and I feel like it's sometimes easier for me to put on my blinders and not want to really delve into the topic of how things impact underrepresented groups, because it can at times feel a little bit overwhelming, and maybe at times make me feel a little bit of helpless because of all the changes that are happening. And so again, having an opportunity to be vulnerable and brave, just being honest about some of those emotions that were bubbling up within me. But then I think about my patients, and I think about my patients, as I mentioned before, that come from underrepresented backgrounds that would maybe never kind of come to the surface in terms of needing care or needing to look at their relationship with food, had it not been for someone kind of opening that door. And so one example, and it was so interesting, I was like, what patient am I going to talk about? And then literally this week, I had a woman that just so illustrated this for me. This was a Black female in her 60s, and she was referred to me by the oncology team. I thought, this is an odd referral. And I look, and the woman has metastatic colon cancer and her body weight is low. And I'm thinking, this seems, like that would be a natural thing that could potentially happen within the course of her illness. I'm just curious as to why she was sent to me for an eating disorder referral. So I'm excited to meet her. We delve into our conversation. And so this lady, we'll call her M, started telling me the story of her life. And it is very steeped in kind of that IFS model that we're going to be talking about today. And she says she grew up initially her younger years in Chicago within a very tight knit family. Her mother was regarded as being this beauty. I think she even said she was like, used to be like a model at some point. And then she was born and she was regarded by the family as being larger than other people in the family and was given the nickname Fatso. And that followed her throughout her life. She said she remembers from a young age just always feeling like her existence, her opinions, nothing really that she said or did mattered because she was living in this larger body and she was disregarded and perpetually teased by her family members, which when we think about cultural context, sometimes that is something that has been perpetuated within certain cultural groups. And she just recalls how challenging that was for her emotionally and how she really dealt with those emotions by further engaging in binge eating, which we so frequently see with our patients, is that she further engaged in binge eating to kind of soothe these wounds, this traumatizing experience that she had had. And she spent her entire life trying to deal with the discontent that she had with her body and the negative way that she felt about her body. She went on to get an advanced degree, but at the same time had multiple, I think she had a gastric bypass, a gastric sleeve, and oftentimes these surgeries were minimally successful, again, because she had this underlying binge eating behavior that had never been addressed. The emotions of her eating had never really been fully addressed. And so it wasn't in her mind until she finally got into her, I think it was like around her 50s, that she found yoga, and she started becoming, very involved in yoga and being very restrictive in her eating. And she was finally at a point in her life where she felt accomplished, where she felt like she had met the goal that she had been seeking her entire life. And she felt like she was finally given some sort of regard by her mother and by her family. And she was rapidly losing weight, continued to lose weight, and ultimately went to go get medical care, which I believe she had been kind of disregarding up until that point. And it was at that point that it was found out that the reason why she had been so rapidly losing weight was not because she was doing yoga and eating vegan, but because she had this very advanced metastatic colon cancer. And so here she was finally achieving what in her mind, and I wrote down some quotes, they were so poignant, but just like this goal I had been seeking since as long as I could remember. I had finally achieved it. And now people were telling me, no, 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 you're too small, you're too thin. And the doctors were telling her, you need to gain weight so that we can heal you from this illness. And she said that threw her brain into a tailspin. She really could not, despite the fact that she is facing this fatal illness, and being able to improve her nutrition and everything could help in that healing process. She said, I cannot get past the idea that this is what I have worked for my entire life, and that people are trying to take that away from me and they want me to eat more. And so she has been trying to eat a little bit more. She's also had some surgeries that are making it easier for her to eat a little bit more. And she said, I'm gaining weight, and that is what has me petrified. I am completely uncomfortable in my skin. I am completely unhappy. And I am not okay with what's going on because I am giving up this goal that I had worked for. And it was just I mean, I had to, it was like a gut punch listening to this story and listening to this woman's pain and recognizing, that this really reflected a lot of what we're talking about today. This woman who had gone under the radar, that all of these years had only been presented with options to make her size smaller, no one had ever really recognized the fact that she was struggling with this disordered eating. And now, where she's kind of on this horizon of dealing with a very fatal illness, that even in this moment, she cannot let go of the idea that she needs to be smaller, that she has failed and not really be able to nourish herself appropriately. And within all of that, the irony is that because she's not able to work and has all these health issues, has had to move back in with her mother, who she sees oftentimes as being the catalyst to a lot of this poor body image and all of the messaging that she's receiving with being in that space. So just going to take a moment and pause there, and take a deep breath, just because that to me is kind of why I do this work. And that to me really reflects, kind of what our conversations are about today. And I just want us to see, this woman that has gone unseen for so long. And it was only until her weight got so dangerously low that she finally, in her 60s now, has come to the you know, to under the radar of getting some help, and just all of the decades that she's suffered. So now we're going to move into solutions and strategies. So you guys are already doing step one, and that is educating yourselves, coming here, learning more about how eating disorders can show up in, various ways that aren't the classic traditional images that we're used to seeing. Recognize that sometimes our own biases, or sometimes the biases of the professional communities that we operate in, may impact whether or not someone comes to the forefront in terms of being recognized as having an eating disorder. And that as we work together to do this culturally competent training and look at more inclusive models, we can improve care. We can recognize these people that are suffering much earlier. We can bring to them treatment modalities that meet them where they're at, and recognize the full breadth of what has brought them to this point, and then can move them towards healing. And we know that weight neutral and culturally sensitive and competent care is essential to us being able to help so many people that are struggling move towards that recovery that we seek for everyone. So in terms of action, we talked about what we can do individually in terms of educating ourselves, the type of care that we want to provide, but we also know that advocacy for access is so crucial. As I talked about, there's so many people, the people that actually make it to get care are a small percentage of those that are struggling. And the more we can advocate for opportunities for people to get access, for funding, for research, and that is really what's going to help reform care and make it more accessible to people. And we know that policies must support equity of eating disorder treatment regardless of someone's body shape, size, or identity. And we know that those of us that have worked in those eating disorder spaces, oftentimes it's very challenging to get care for patients unless there is some type of catastrophic medical situation. And so we really want to be kind of those ones that are out there advocating for and illustrating these stories that show why access to care is so important for a wide variety of people, and that we shouldn't have such a narrow focus in terms of how we determine who needs what level of care. So in conclusion, to reduce stigma and improve outcomes, we must create inclusive, affirming healthcare systems. And you guys are doing that work by being here today and being open to the conversation. And we know that support and unity can really drive lasting change. And so I'm so excited about the fact that we have this platform. I'm excited about opening up to hear your feedback and your comments. And I'm just excited to see how this has evolved. I often tell the story. The first time I ever talked about eating disorders and marginalized groups at this point now was probably, I don't know, close to 20 years ago. And I was at a conference and there was only a few people that showed up. And I remember the door opened and I was so excited. I thought, okay, I'm going to get one more person. And they were only coming in to get a chair to take to another room that was like heavily populated. And I was just remembering how that took the wind out of my sails, but I was grateful for the people that were there that were open to the conversation. And I'm just excited to see how as a professional community, our interest in this work has evolved and will continue to evolve. And so thank you for being a part of the solution. And so now I'm going to open it up to questions or comments. And I just thank you guys for the opportunity to be here.
Awesome. So it looks like we have let me turn my camera on. So it looks like we have a few questions here. A couple of them came from Dr. Angela. The first one that she said was, you noted that marginalized patients often avoid care due to medical mistrust. How might we begin to repair trust in communities that have experienced historical and ongoing harms, especially in ED contexts? I'm considering the historical trauma of the Tuskegee experiment or modern day maternal mortality rates among Black women that contribute to medical mistrust.
Thank you so much for that question. And it's interesting. That's a question that we often have even within my own institution is like, what are the ways that we bridge trust? And I think part of the ways that we bridge trust is first acknowledging the fact that those things did occur. And I think that historically, disregarding that has also led to further mistrust. I also think it's important for us to be able to provide care. You know, one feedback that I even give at my own institution, it's like when they're doing a research project and they really need diverse groups, all of a sudden they're very, very open to like going into the community and opening up, trying to get patients to do research. But that's not the way that you go about gaining trust. You go into the community and you provide services. You make a pipeline for them to be able to get the help that they need, that they are seeking. And then once you're able to like build that rapport, that's when, if there is a research project or something that opens up, people are going to be much more likely to engage in that because they already have a relationship with you. They don't want to see people only coming into their community when they are needed for that other person's agenda. And I think it's also important for us to really work towards having kind of diverse professionals, right? I think that the more patients have an opportunity to seek out someone who they can relate to that has a similar background, that also helps build trust. And even if that person isn't their primary doctor, but just knowing that within, let's say, this one particular practice, when I look at their website, I see that they have people of all different backgrounds. So I know that I'm going to be welcomed there. But if I open up a website and I see nothing but people that don't look like me, then it feels like I'm not valued. And so I'm already going to go into that situation with a level of mistrust. So I think those are some avenues that we can all work to kind of build that trust. But I think first acknowledging the kind of transgressions of our past is really important. And I know that one book, I think it's Medical Apartheid, which is excellent if you guys haven't read that, which kind of delves into some of that. Any other questions?
Hi, Dr. Williams. I'm going to take over for Bethany for just a second, and I'll see if there's another question that popped in.
Thank you.
And there's a question. I went to a new primary care physician, and she had the BMI guide sitting right in front on the table next to the exam. I told I told that I told that I was an ED specialist and recommended against and explained how this could cause pressure and discomfort for patients. Do you have any input or feedback on how individuals can assist in talking with primary care physicians?
Yes, that is a lot of the work that I do is actually talking to my own colleagues about weight stigma within our spaces and how we can eliminate that. So I think that being an advocate the way you did that, congratulations, because that's very brave. And trying to do more of that. I know myself, I even have to go around my clinic and take down the BMI charts and explain to my colleagues why that is not ideal, and to give them a little bit of historical perspective on BMI and why we're moving away from that, as it has unfortunately been a surrogate for health for far too long. There are opportunities if you have patients that are concerned about going into their health spaces. There are these little don't weigh me cards that basically say, like, unless there is a specific reason for me to be weighed, I would prefer not to be weighed or to discuss weight during our conversation, because oftentimes patients feel that that alone is very stigmatizing. And I will say, from a primary care perspective, this is something that is evolving, but historically, like, they have, I'm happy to say, in my current chart, taken BMI off of where it was kind of on that dashboard, and it was something kind of yelled at you, if you will, when you opened up a patient's chart. And there was even a time when it would kind of give that as like, hey, you didn't do anything about this. And so I think, advocating for, our medical health records to try and remove that, to be more focused on other, more objective reflections of health versus, where we have been historically with so much focus on weight and BMI. But I think, empowering patients that they don't have to be weighted every visit, the don't weigh me cards, the having the conversations. There's even like a longer letter I think you can send to your primary care provider, but the don't weigh me cards are easy and quick. But just being out there. And then if you have an opportunity to speak to medical providers within your space, taking that time. I know I definitely try to speak at national conferences and things on this topic. And it is challenging because for a lot of physicians in particular, it definitely requires a bit of a paradigm shift. So I think it will take some time. But on a word of encouragement, I also teach medical students, and I do feel like the younger generation of physicians, that training is much more open to this. And I feel like over time, we will see more of a shift.
Awesome. Well, thank you so much for answering those questions for us, Dr. Leslie. So now as we are moving forward, I'd like to transition right into Mimosa Collins, and she will be tackling the next portion of this training. Thank you so much.
Thank you so much. I'm just going to set up my presenter modes here. And Dr. Leslie, I so appreciate a lot of what you shared. And I just want to speak for some of my parts that felt like I wanted to say more than I could in 35 minutes. And it means it was really helpful to remind my parts that I'm in this presentation with other presenters, and I'm really feeling the evidence of that right now. So just speaking for that gratitude that my parts are holding for sharing this stage with the presenters today, and also the presenters yesterday. So I'll go ahead and share my screen. Coming over here. Oh, let's see. Gonna move this out of the way. Okay. All right. So I am a registered dietitian, and as such, I will be representing the niche of my talk today is going to be how nutrition science is complicit in centering the needs of some while excluding others, and therefore perpetuating this phenomenon that we're in now of having underrepresented populations in the eating disorder treatment field. And specifically, we're going to look at the traditional approach to medical nutrition therapy in eating disorder treatment, very focused, very niche. And we'll consider who benefits and who is excluded within this approach. And another way that I like to think about this is what I mentioned earlier of whose experience and whose stories, whose reality is centered and whose is kept on the margins, pretty intentionally so as well. And then finally, we'll look at tools that IFS offers as a way to correct this imbalance of who is centered and who is not. And I'm grateful for the chance to speak about how dietitians in particular can incorporate IFS tools, as it is a therapy modality and therefore often associated with therapists, appropriately so, and also dietitians who focus on behavior change can also really benefit from these tools from IFS. And I just want to say, give a little shout out of appreciation to the dietitian that spoke yesterday, one of the dietitians, Marcy Evans. I can tell I'm in good company when she's also speaking to how internal family systems can deconstruct the dietitian as the expert, or at least speak to the benefit of not positioning ourselves as an expert when we're interacting with our patients. And how that can bring everyone's humanity more into the room. And reclaiming our own humanity, I think, can be a really powerful shift in how we correct whose experience is centered and whose experience is dismissed. And in that spirit of reclaiming humanity, I want to share just a little bit of my lens as a person in this world. This is a picture of me and my family. This one's me. I used to think the point of smiling was to show as many teeth as possible. So there's a phase in my life where I'm just growling at the camera. But this is me, and I'm sitting on the lap of my mother, who is a cisgendered white American, and my father is a mixed race cisgendered American, and my race is somewhere in between the two of them, often passing as white, depending on who you ask. I have an abundance of other privileges, including being cisgendered, able-bodied, neurotypical, and straight-sized, and those privileges in particular impact my work as an eating disorder specialist. And it's important for me to acknowledge my privileges, mostly to myself, but also to this group as I speak to you, because as a result of my privileges, I have blind spots. Part of a privileged identity is that we don't need to know the experience of people who are oppressed in relationship to our identity. And so it's important that we are aware of our privileges and intentionally correct those blind spots by going to talks just like this and being open to being called in by people who are maybe are harmed by our ignorance about their experience and how we can impact and cause the harm for them. And as I kind of reach for correcting this phenomenon of having underrepresented populations in the eating disorder field, I'm really appreciating what Amy Pershing said yesterday about how really small gestures are really important when trying to change the status quo. So these disclaimers that I have are also invitations for all of us to practice little small changes, even in this talk today, that might lead to disrupting the structures and systems and norms that perpetuate this phenomenon of having underrepresented populations. Number one, we're all in this together. We're all learning together. Like I said, I have blind spots as a result of my privileged identities, and I'm learning as alongside with all of you. And that's true also in my professional life, in my work as a public health nutritionist. I definitely perpetuated the harms of weight stigma, and I didn't know better. And luckily, I took the effort to learn and know better now. And so now we have to do better. The other invitation or disclaimer is that your experience matters, your parts matter, just like we said kind of at the beginning of our talk. And I really appreciate what Dr. Angela said about how we all experience oppression. And I would even argue that even those of us who hold privileged identities within an oppressive structure also suffer. Even those who maybe benefit more, or who absolutely benefit more than those who are intentionally oppressed within that oppressive structure, we still suffer within that structure. And so I think it's important for us to identify how all of us suffer in oppression so that we can embody the truth that all of our liberation is truly tied together and become co-conspirators in this reach and work of liberation. My third disclaimer, and this one's more of a disclaimer, is that I do intend to use the term fat a few times in this presentation in solidarity with fat activist communities that want to reclaim that word as a neutral descriptor of a body. I also recognize that I hold the privilege of being in a body that is straight-sized, and my use of that word may not feel liberatory for people who have experienced weight stigma because they are in a fat body. And so if my use of that word does not support that liberation, that reach for liberation, please let us know. I think I still can access the chat. Yes, I can see the chat. So please let me know, either direct message in the chat or publicly if you would like. But your experience, like I said, matters, and I will adjust my behavior so that I won't cause harm in using fat as a neutral descriptor. And then finally, as we, and I can tell based on the presentations yesterday and also Dr. Leslie's presentation just before mine, I'm in good company. I'm in a group, I'm in a community that values stories just as much as research. At least that's how it felt when I was attending the presentations yesterday. And so this is an invitation for us to just be mindful of what sources do we or parts of us consider as legitimate, and which sources or stories do we feel are dismissible or disposable and invalid. All right, so let's dive in. Number one, traditional medical nutrition therapy and eating disorder treatment. Okay, as I begin this talk, this topic of traditional medical nutrition therapy in eating disorder treatment and how it perpetuates underrepresented populations in the field, I'm going to take a cue from the host of one of the podcasts mentioned on yesterday's panel, Aubrey Gordon, who hosts the podcast Maintenance Phase. And she's a fat activist who says that when we talk about weight stigma, we have to tell the whole story of weight stigma and its anti-Black roots in the 1800s. And so I'm going to take a cue from her. And as I talk about underrepresented populations and eating disorder treatment, I want to also include the whole story of the medical industrial complex and its anti-Black and anti-Indigenous roots in centering the needs of white Americans. The image on the left is called Real Rent Duwamish, and it represents a tribe that was displaced here in Seattle and continues to be denied federal recognition. And the story that I feel is important to name is that early settlers used their knowledge of medicine and disease to erase Indigenous populations in the U.S. for the sake of making more room for white settlers to take land. Here in Seattle, we acknowledge this harm and pay respects to the original stewards of Seattle by paying real rent to the Duwamish tribe. That's one way that we in our community try to acknowledge and somehow reach for repair for that harm. And of course, that's not going to be enough. The image on the right is from the Tuskegee syphilis experiment. This was conducted in Alabama, and it was actually a government-funded research that used Black Americans to understand the long-term impacts of syphilis without their informed consent. And this is part of what has disrupted, or at least this is part of the legacy of the medical industrial complex that contributes to the disruption of trust in marginalized communities. To make matters worse, when penicillin was discovered as a cure in 1944, it was withheld from the test subjects who had by then infected their families. And this experiment and this approach may feel like a long time ago, but the participants would have been our generation's grandparents. So it's actually a lot closer than maybe many of us want to admit. And as we talk about underrepresented populations today, you will see that the eating disorder field has been continuing this legacy. And I really appreciate what Dr. Leslie shared about her grandmother and how her grandmother was basically, one could argue, a test subject. Dr. Leslie, I hope it's okay that I bring your story in here. Because this legacy continues in various ways. And it directly continues in eating disorder recovery. In 2020, the International Journal of Eating Disorders reviewed their research that had been conducted between 1980 and 2020, and they discovered that in those 19 years, only 2.5 of the studies published had been looking at eating disorders in Black and Indigenous people. 2.5% of studies published in 19 years. I'm just going to let that sink in a little bit. And because there's a lot of implications about this finding, from bias in the field to funding. And I just want to take a moment too to acknowledge when we speak about funding, and I appreciate Dr. Leslie for naming the political climate. It was really hard putting this talk together and study after study, seeing the need to bring more research in to fill the gaps about eating disorders in underrepresented populations, and knowing that the federal administration right now is pretty directly attacking DEI efforts in research specifically is really, really tough. So getting back to medical nutrition therapy, just taking a minute, bringing our focus back into how internal family systems and tools from internal family systems can help us make those little tiny adjustments and move toward interrupting this huge system that has brought us to where we are today. On the left are the traditional nutrition eating disorder treatment goals. They begin with addressing medical instability in the body, and then once that is established, they expand into more psychosocial recovery. This priority of medical stability in the body can contribute to a sense of coercion, especially in higher levels of care. And I just want to elevate the work of Dr. Jeannie Wang Hall, who speaks a lot to the carceral elements of higher levels of care. So I want to just bookmark that if you want to learn more about that. Jenny Wang Hall has a lot of work there. But the tools that we're going to focus today's discussion around, or at least my discussion around today, is these 4 tools that dietitians often use in supporting people in their recovery: the assessment, determining levels of care, calculating target body weight, and creating a meal plan. So as I did before with starting at the beginning of the story of underrepresented populations, well, the assessment is where we can start making changes in how we support people in their recovery, because it's in the assessment element where a lot of people are missed, just like Dr. Leslie mentioned in her talk. It's worth saying that the stereotypical person diagnosed with an eating disorder is the small white affluent girl. And this came to be created both through media as well as early research in the ideology of eating disorder treatment. So it's not just media. The field has definitely perpetuated this stereotype. And to a degree, one of the strongest determinants of whether or not someone will get treatment is their socioeconomic status. But prior to the point of recommending treatment and then accessing that treatment is receiving a diagnosis of an eating disorder. And the strongest factor for receiving a diagnosis is how closely someone resembles the stereotype of someone who would get a diagnosis, aka the small white affluent girl. And it's really important that to recognize that our assumptions have real impact. And this is particularly true for people who have intersecting underrepresented identities, such as BIPOC youth who are also fat. And I want to illuminate or highlight that one study presented a case scenario to clinicians of someone with eating disorder behaviors. Different groups of clinicians examined this case, and the only difference between the groups was the case's race. And when the case presented as white or Latin, she was more often diagnosed and referred for treatment than when she was presented as Black. And when she was presented as Black, even though it was the same case of behaviors, most providers failed to diagnose as having an eating disorder at all. And I just want to take a moment and share that I have a friend who is a Black woman in her 60s who has struggled with an eating disorder her whole life. And when she was seeking support in her mid-30s, she was told by her provider that Black women don't get eating disorders. And she's still struggling in her 60s. As we acknowledge this error and missing in assessment, I want to also note that 72% of eating disorder professionals are white. And remembering that the more privileged identities we hold, also the more blind spots we have. And if we have a workforce that's 72% white We need to be really diligent about the assumptions we're making based on what's familiar rather than what may be true or in front of us. So what are the tools from IFS that can help us identify these stereotypes? I really appreciate the parts language because it allows us to acknowledge our shortcomings without crumbling in a sense of defeat. We can own that we're imperfect and that parts of us may struggle with that admission. And one way that I want to offer as a tool for identifying bias is to ask a question that challenges that bias directly and notice what parts of us protest. For example, what comes up for you when I say any kind of body can have an eating disorder? I'll say it again. Any kind of body can have an eating disorder. Now, because we're in this group, this room together, there might be a loud voice that's like, duh, because that's what we're talking about today. And I just want to invite us to take a moment and listen for whether or not there's a subtle pushback to that. If there might be a voice that's like, are you sure though? And it's important not to shove that voice of doubt aside and to really be with our parts who feel confused so that we can build trust with them and they don't feel like they need to run the show when we're with our patients. Okay, so once someone's assessed, we often recommend a level of care. And this topic came up a lot during the panel yesterday. And when developing nutrition goals, level of care, the nutrition goals change depending on someone's level of care. And there's often an assumption in the field that a person begins at the highest level, aka hospitalization or residential, and then they'll take the incremental steps to gradually expose themselves to a more sustainable living environment and less structured support. And that assumption means that you need to have a lot of access, which not many do, as we discussed, as Dr. Leslie spoke to in her presentation. And it also means that people aren't getting the support that they need to implement the changes in their food if they can't do that drop down level of care. Many people maybe say, I have no problem not engaging in my eating disorder behaviors when I'm in a high structured situation. But if I go directly to outpatient from there, which I have to do because I can't afford the other levels, then I'm at a loss. I feel adrift. So making those assumptions, again, checking our assumptions when creating nutrition goals is important to do. And IFS really helps us in checking those assumptions, partly because of the element of deconstructing the dietitian as the expert. We don't have to come up with the nutrition goals. We can check with our patients and our clients and see what nutrition goals feel meaningful and accessible and realistic for them, given the resources that they have access to. Another element that I really appreciate about IFS is that not only do we have to know the right goal to set, but we also can follow the client when it comes to pace, how quickly recovery needs to happen, and also language. And one of the ways that I try to honor pace is that I speak about this, I talk about the option of higher levels of care before there's a medical urgency and need around it, so that clients' parts have informed consent and know that that's an option before my parts that get worried about their medical stability get too activated. And if I want to speak for those parts that are worried about my client, I always ask their permission to see if I can speak for a part, as with an intention to give them informed consent so that they know all the risks of not going to a higher level of care. But ultimately, it's up to the patient. At least that's how I practice in my practice. And I think that's how IFS can really support us supporting our clients' agency and autonomy. Another reason why I think language is an important thing to follow is that not all patients feel like eating disorders apply to them because they don't see people who look like them in fields that use the term eating disorders. And Dr. Alicia McCullough, author of Reclaiming the Black Body, speaks to this phenomenon and uses the term unbalanced eating with both her clients as well as on her own journey of recovery. All right, next. And one of the things that can influence a patient's determined level of care is their target body weight. The traditional ways that we calculate target body weight in dietetics is an equation that uses gender and height, both in adults and in adolescents. And of course, when it comes to gender, there are only two options, male or female. This clearly excludes trans and gender expansive individuals from this whole process, not to mention that the BMI, as mentioned in the adolescent element, is problematic in and of itself, as we discussed earlier. And Dr. Leslie mentioned how weight neutral care is a really important shift to make in treatment centers and supporting people in eating disorder recovery. And I'm right there with you, Dr. Leslie. I would argue the same. And instead, what I recommend and what I do with my patients is work with them to identify other meaningful measures of malnutrition, such as lack of sleep, hair falling out, GI mobility, other elements like this that are also meaningful for them. And this is, again, where IFS can support us in checking in with our patients about what is important for their parts, what fears come up when we talk about evidence of malnutrition, and how can we co-create treatment goals that support the correction of the malnutrition happening in the body that doesn't activate the parts. Because there's sometimes malnutrition evidence like losing a period for people who are womb holders. That can be really activating when a period resumes. And so being with the parts that are fearful about that potential and really going at the pace of the client is really important. Again, emphasizing that their experience matters, your experience matters, my experience matters. Practicing that small shift as we disrupt these large systems of oppression. Let's see, I have some notes here. Okay. Oh, this is where I share some personal things. So one of the personal stories I wanted to share, excuse me. I have a part that must be worried about me sharing this. Is that I have a story as a mixed race person. Growing up in a predominantly white space, my third grade teacher said that some people are Black, some people are white, but most is yellow. And at the time, yellow was my favorite color. And I was like, all right, that's cool. But then I came to learn that maybe that wasn't such a great thing. And there was an othering that happened. And the othering and this belief that I was different because my environment wasn't mirroring me or honoring my experience, created the protectors that then led to behaviors that were consistent with eating disorder behaviors, because these protectors were trying to support this exile that felt like something was wrong with me and needed to be corrected, right? And I really want to take a moment and just acknowledge that not being reflected in an environment, in eating disorder treatment, or in the world, the impact isn't just feeling left out. It can reinforce this idea that there's something inherently requiring discipline and correction. And this is, I'm taking this quote that you're seeing on the slide here, from LGBTQIA identified individuals who also identified as having eating disorders or having had eating disorders and their experience in treatment. And because their environment around them didn't reflect their experience, and neither did the conversations that they heard from their fellow providers, there was a sense of that not only were they not part of the norm, but that they should be. And even in their treatment environment, there was this sense that they needed to correct themselves. And it's worth saying that 84% of eating disorder professionals identify as heterosexual or straight. And this is another element, an area of underrepresentation that is negatively impactful for our clients, not only in the tools that we use, like calculating target body weight for people who are in fat bodies or don't align with the gender binary, but also because of just the discourse that we have. There was some conversation yesterday about, I think it was Dr. Olivia Pryatt talking about the shame when we don't live up to cultural norms. And, that shame can also lead to the creation of an exile that we know creates these protectors. And as Dr. Leslie spoke to, when there's limited options for how we can change ourselves to fit the norm, that just lends itself to creating eating disorders as a way to try to fit in and function and make sense of what's happening. So I just kind of wanted to bring the humanity into that phenomenon of the impact of not being in the center, of being othered, of not brushing your hair in the morning as part of your getting ready ritual because your hair texture doesn't follow that norm, which other people assume is what everyone else does. These little things, when added up, can create this sense that there's something inherently requiring discipline and correction within us. Whew, so thanks for letting me get on that emphasis. And the final tool for recovery that dietitians often use is meal plan creation. And the meal plan in eating disorder field is not, it's not unique. It's part of nutrition science as a whole, perpetuates a Eurocentric model of what is healthy food. And the attack on MSG in the 1960s is one example of vilifying a perfectly healthy food product because of racial bias. The Chinese restaurant syndrome was seen as a legitimate medical complaint, and poorly created pharmaceutical studies perpetuated this idea that MSG is a problem. And it wasn't until 1995 that the FDA finally determined that was generally recognized as safe. And even so, when I was a nutritionist in the health field, as late as 2015, we were still talking about MSG as something to avoid. So even though the FDA in 1995 was like, actually, it's good, that takes time to change in people's minds. And that's one example of how racial bias can show up in the food science and nutrition field. And it's not just the Chinese cuisine. There is definitely anti-soul food evidence built against soul food or the Southern dietary pattern. And one study conducted as late as 2021 attributes this dietary pattern to the disparities of stroke and hypertension in Black people in the South as compared to white people in the South, absolutely disregarding the impact of race or discrimination in that disparity. It's also worth noting that 82% of registered dietitians are white. We're seeing patterns here as we talk about the elements that keep underrepresented populations in the margins. This field is predominantly white and straight. And I'm noticing the time, so I'm just going to briefly say that the same tools that are helpful from IFS in correcting these biases in nutrition, of checking with our own parts about what we believe to be helpful, is also applicable here. And while IFS can't teach us about different food cultures, we can check our biases, and also as dietitians, we can create templates of meal plans that allow for food culture to be expressed, food culture to be honored. And sometimes when I'm working with someone on a meal plan, and there's a part of me that wants to offer another perspective to debunk a myth about food, such as MSG or something else, I always ask permission, and I always offer it as another perspective, again, continuing to dismantle myself as the all-knowing expert. So here's a summary slide just to capture some of the points I was making. And I also just want to illuminate or bring our attention to the next steps. I love that everyone is here today. As mentioned earlier, this is an important part. And the most important next step, I would say, as I've heard echoed in this conference, is to get to know your own system, working with an IFS therapist, or seeking supervision either in a group or individually. I also want to shout out conferences coming up that also continue this conversation about how we can disrupt this phenomenon we're in, which is having these disparities in different populations in the eating disorder treatment field, and also encourage people to do some intentional race identity development, so that we can get closer into understanding what are, especially people who are white, who haven't needed to know the impact or how whiteness shows up in ourselves or in our greater society. I really encourage us to develop that work. And then also consider investing in different communities such as the Healer Circle. Shout out to Dr. Erica Taylor. It was a conversation I had with her that inspired me to join the Healer Circle as part of Project Heal. And there are many other communities and professional groups that are supportive in more development in this work. And then also those of us who love books, these are some great books to continue the conversation in unlearning and learning. And then also want to encourage people to find YouTube and content creators on social media. Not everyone can publish their ideas in books, and they're still worth hearing their ideas. And I just want to end with this quote by Reverend Jennifer Bailey. Relationships are built at the speed of trust, and social change happens at the speed of relationships. IFS is a relational model focused on building trust between self and our parts, and it's a relational model that I believe has the potential for social change. Thank you all so much for listening.
Mimosa, thank you so much. We are now going to go into a 10-minute break. So plan on coming back at 1:33 p.m. Central Time. And feel free to Hello, everyone. Welcome back. Next, we have Jean, and Ines speaking. So prepare yourselves for that. I know I'm excited.
Ines.
Morning or good after. It's still afternoon. Yeah. Good afternoon. Mhm.
Gina and Enos, I think it's okay for the two of you to start, and when you want me to play that first video clip, let me know.
Perfect. Welcome, everybody. Welcome back. What a great morning.
Yes.
Right? What a great conference, but what a great morning. So glad to be here today with you.
And
I just wanted to name before we begin that I am a week out of some major surgery and I am doing well. I'm very grateful. I'm also taking some medications that are making me feel a little bit both wired and also flat at the same time. So I'm calling in some good self energy, but just to let you know, I may not be my usual. I hope to be as close to my usual because I'm so excited to be here. I think that will happen.
And I also just want to say that I appreciate being able to be with you today, Jean. And it's really sacrificial that you have, saved up your energy and are able to be here in such a weighted part of this session. So,
Enos, do know in no small part to your self energy throughout this process. And you named earlier that you're a nurse, but just who you are as a person and your self energy. So I feel people will see that in our relationship, kind of that energy, but just wanted to appreciate it now. Yeah. Privilege.
I think we also both wanted to kind of say that we chose to do this IFS session. And really, having been exposed to IFS since 2002, a long time ago, with Dick and with Jean, I definitely approached doing the session without any agenda or making any decisions or thinking about what should I work on or anything like that. I just came with a knowing about IFS and having worked in the field that included so much IFS. I was actually trained as well by Dick. So to the best of my human capacity. I came to that session without a specific agenda or any idea of what would come up.
Mm-hmm. Right. And should we name a little bit about when we met? We think this was in October. It was October shortly before the election.
Mhm.
And we both live in the same part of the country, more or less. I'm north of Chicago, and Ina's here in St. Louis, right?
Mhm.
And so both came in with a certain amount of on edge, certainly, on edge, on alert, but pre-election. But I also had no agenda whatsoever. And that felt important to me to not have any goal about, oh, this needs to be eating disorder related, or it needs to be, we need to head in a certain direction. We'll speak more to that later as we go, that sense of not holding an agenda, certainly for either person, but the practitioner in particular. And also, we didn't know each other super well. We were familiar with and liked each other, right? And
Yes.
got to know each other more last year at the last conference. So yeah, so this was another opportunity to get to know this special person better, and I was looking forward to that. And that's what I came in with, just a lot of curiosity. And so we do have quite a bit of a session. We're only showing parts of it, right? In a sense,
Absolutely.
we
We put
selected
together some
out.
clips. Mhm.
But I want to say that we also spent a lot of time, which was very rich, speaking about our respective experiences and all the different aspects of the IFS model that contribute to more culturally competent care in our experience. And so we may speak to some of that may come out in the video, and other in the remarks that we make, and with regard to certain clips that we chose. But there were so many moments that we could have chosen, and so some of the aspects will be borne out further, have been borne out by some of the discussion you've heard from Dr. Leslie and Mimosa already, some of the important aspects, but then borne out with Dr. Taylor's and Dr. Zhang, and also our moderated panel, Dr. Angela, in the moderated panel. So we're just going to ask you to kind of trust that some of these things will emerge more. And I think as much as possible to also be rooted in curiosity with what's coming up in your system. I think, Ines, you might want to add to that.
Yeah, I think that it was a time for me that I allowed myself to be very vulnerable. And some of the things that are in the clips that you'll see are really weighted concerns and surprised me. So yeah, I really am inviting everyone to be checking in internally yourself and just trying to understand this in the bigger context of what this particular session or part of the afternoon is about. So I think we're just going to delve into it. And our strategy is to start a clip, it'll stop, and we'll try to share with you our perspectives about what was unfolding.
Right, and then we'll allow some time for Q&A.
Yes.
Mm-hmm.
Oh, I also advise everyone to put on your closed caption to help with volume. We touched on some heavy things about things going on in the world today, and so I find myself there's a part of me that can be want to be very aware. There's other parts of me that is just exhausted with it all. It's exhausting, and a lot of uncertainty in our parts that felt overwhelmed and flustered by it all.
Right. Okay. So you've got parts who really want to attend to what's happening, be aware, right? And then others who are really tired and don't want to, or kind of like to not flooding in.
Just get overwhelmed with all so much. I guess I don't know why everybody doesn't want the best for everybody.
Right.
Like, why do we have people who,
Right.
For whatever reasons, fight so hard to keep us all at odds with each other.
Right.
Did you want to start by saying what that was like for you, or?
I definitely what really spoke of what just came up, and so I was surprised that it was this heaviness about feeling very uncertain about our future and our future here in America, but my future as a Black woman in a Black body, and what that experience has been like. First of all, in America all my life, but certainly in times that felt scary for me. So that just jumped right out front and center. For me, represented real and present danger on the horizon.
Yeah. Yeah, and it didn't surprise me at all that emerged for you. I mean, we didn't have any sense of what we were going to do, but it made so much sense to me, and I felt like I just wanted us to give a lot of space and room to be able to hear whatever parts of you needed or wanted to say about that. Right, so that's what we were doing.
And I do recall having an initial sense of kind of like a whoa, I don't know how this will be received, because nothing in me wanted this to be something that was polarizing or that would be seen as politicizing in any way, because it really was just my own very real sense of distress as a Black woman in this big Black body. I am a Black person who is, I want to use the term fat because I am embracing that as I have been inspired by Aaron actually since 23. But I had a part that was wanting to kind of censor that and say, whoa, this could go kind of sideways if this is what's coming up. But I just asked that to just settle down and was willing to just go forward. So.
And so we're only showing clips, but we did speak a lot about our experience while we were doing this. And one of the things was that I noticed that was a part you spoke for a number of times. And one was like, is this okay? Is this going to be polarizing? And I thought, well, in my experience, when I checked in with my system, it was like, this is what's happening, right? This is very real, right? That this is a very real danger. It's a very real danger you've been living with for such a long time. Of course, we're all living with it in certain ways and in certain degrees right now in this culture. But the more we made room, I feel like the more we spent time with this session, we really got clear about how, for parts of you, it felt risky to even name, right? To just name in this opportunity right now that we're creating. to be able to name this fear and this danger that parts of you are carrying, right? Isn't that there was
Absolutely.
a risk attached to it? Mm-hmm.
And the other thing that is really important for me, for this audience to become aware of and to observe throughout, is that because Jean was able to just sit with that, I felt so witnessed in a way that also kind of quelled the concern about where this was going.
Mm-hmm.
You know, we represent two women who have had very different lived experience, and so
Mm-hmm.
there was an immediate powerfulness in just being witnessed.
Mm-hmm.
I didn't feel judged about what I was saying. I just felt I was being seen, and that
Mm-hmm.
carried through the whole
Mm-hmm.
time. So
Mm-hmm. You know, I'm so glad you felt that way. And then one of the things I think that was true for me is that if I had had a part that felt like I needed to do something, like if I had been blended with a part that felt like, oh, I need whatever part I felt bad that you were feeling this way, or felt like I needed to get you to feel better, or whatever, or had a part that blended with me that was minimizing, that had minimized it. Like, we're talking about dismissing, whose stories get dismissed, like minimizing, oh, it's not that bad. It's, um, that would have been a much different experience for both of us. Right.
yes,
So it was really important for me to just keep being curious. Like I need to trust your system to reveal what feels comfortable to your system to reveal. And so that's what we're doing right here, is helping to create that. And your protectors set the pace, as all protectors do. And they will, they will share more if they're feeling that they're being seen and not rushed or judged or whatnot. So I appreciated your trust in me in that, and hearing that it was helpful to have the space. Yeah. So
I think we're ready for the next clip.
I think so.
Just because of my own personal connection to, why it all matters. Being a Black woman, grew up in America, of course, born in the mid-50s. So, I'm old enough to feel ancient. And, I know where we've been in this country, and I know where things could go. So, it's personal, but it's also it's also about all of us. So it's not just about me.
Right. And I'm hearing the part that's saying, why doesn't everybody want good for everybody? Right. There's a part who really. Right. Does it feel like that would be a good place to start? Yeah, probably is. Because I don't understand that, and I don't. I don't know how to separate that out from the impact it has on me every day, any given day. It's real. Of course. So yeah, I can't pretend it's not real. No. Right. For me and anybody else. So there's a real clarity, of course, about that. So that's something that you are very present to, right? In all these different ways, personally, and then in the larger, right? And there's a part that says, why doesn't everybody want good for everybody? Absolutely. Right. And so Yeah, just checking in and seeing if are there any parts of you that don't want to make some room for that one? It says, what about? Why doesn't everybody want good?
Well, there's a part right now that says because there is evil in the world.
Right.
I can't control it.
Right. Right. Yeah.
So maybe it's not reasonable to expect that, with enough, with enough connection and input from other people. Everybody would want the best for others.
So a different part that feels like maybe it's not possible. Is that what you're saying? Because there's evil in the world?
Yeah, just that hard reality. There is evil in the world, and there is good and bad. Maybe it's everybody's perceptions can be really different, but there's also good and bad. There's also, I guess I always feel like there's things that people wouldn't want happening to them or anyone they're cared about. So why do you want anything like that to happen to anyone else? So it's this constant.
That's right.
It's a kind of a constant dilemma. We live in America, and you just have to deal with some of those realities every day. And how intense they've gotten over the last 8 years or so is real. We watch it every day, but we also watch people who redefine it as if it isn't that way.
That's right. Yeah. Right. So continuing to witness, right, and hear from these different parts.
And I think Gene and I have watched this session a couple of times together. I've watched it on my own. So it's kind of like a dual witnessing that Gene was witnessing. The reality of how very personal this was for me. But in watching the session, I've also been able to witness that for myself. And I know that Gene began to kind of pinpoint that a lot of the weight of what was coming up was about surreal grief and fear about where we are in this country today. And at that time, again, right before the election was coming up.
I don't want to interrupt you, Enos.
I'm
But
ready for you to share your
well,
reflections.
I think I'm sure you can tell from I imagine you can tell from the demo, from the energy, even from the video, the real presence, Enos, that you had with these different parts who are holding these very, in such profound grief and fear, and then also these questions of, why, and the question about evil, and just feeling just this real, I don't know, this deep presence with it, and just making space for that, which felt really so important to do. And then I checked in with you to see briefly if if it felt okay, right? Which I think, and I felt like it felt okay. I could tell from your being with your parts. You have a lot of self energy, and I also just wanted to check because I felt something that's so important about this model, which is for me being with you, to be with you, right? Not to impose upon you, and to also check, because sometimes there are certain parts you feel okay about sharing, and then others who don't, right? So that's what we were trying to do, keep kind of just issuing an invitation.
Mm-hmm.
Hmm.
Absolutely.
Hmm. And I think also that question of what is possible here, right? What is possible if there is evil in the world, which was emerging in this clip, right? This dilemma of what is it possible to do if in this larger scale there is so much pain and so much oppression, and so I think we were just really holding a lot in that moment.
And I also think that a huge part of the weight of it is that piece about that this is about my experience any given day, because I am always
Absolutely.
a Black woman in this Black body, and that is inescapable. Not that I would ever want to escape it, but
Mhm.
it is an immediate fuel for this
Mhm.
real and present danger.
Mhm. Mhm.
So,
Mhm. And I can tell you that while I was with you in this, and again, it was pre-election, that well, not that pre-election, post-election, I'm still not, sleeping from it. I mean, aware of it, but I had parts that were just so aware of, the amount of fear and vigilance in my system, and just being so curious about your lived experience for so many years, and then especially right in this moment, and just so while I'm sitting there, I'm kind of checking in with different parts who are really sharing with me, lots about that, but being curious. So yes, the sense of everydayness, like inescapability, very present. So,
mhm.
mhm.
Okay, next clip, please.
Okay.
Do you know what I noticed? That every so often you say, so anyway, a part of you comes and says, okay, so anyway. Yeah. And so I'm curious about that part, because it sounds like the dilemma is there is a part of you that's really clear about the personal and has grief about it, right? Grief, exhaustion, a lot of pain about it. And then it sounds to me, I just want to check with you, then other parts that see, kind of see this in the larger scheme of things, and it's like, oh, but there is evil in the world, and so not what are you going to do about it, but kind of gets you away from the personal pain. Is that?
Or draws me in more to the personal,
It does.
because the potential for danger is real.
Yes. So in other words, it amplifies the fear.
I mean, it affects me personally because the potential for danger to happen in this country is real. And I mean, it's also, in some ways, so philosophical and all that good stuff, but it's also very real.
It is, and I'm wondering if the part who gets philosophical kind of again takes a larger view, is trying to do something for you. What do you notice? What do you notice happens when you take the larger view? You said it can amplify some of the fear.
I feel like there's what kind of came up is
Sorry. Okay.
I mean, for me, that's just a continuation of me being able to be witnessed how real this was for me. And I think then moving into the next session, we begin to identify more of the parts of me that are really very much present and show up.
Yeah, I would add that I think that what we're starting to see in this last clip was some of the ways that parts needed to step in to take care of you. Because you need protection, right? We all need protection, but we certainly need protection in a culture that is in which there is ongoing harm. And so when there's a part that can take, sort of, think about things more philosophically or kind of, give us perspective in a way, it's certainly giving us perspective, but there's a way in which it can take us away from the direct, more, direct, intense pain and grief and do other things. And I think when in this part of the session, we're starting to learn a little bit more about the parts of you that learned how to take care of you, that were forced into, rather. Forced, right? Forced, because it's not an election. It's being forced out of their naturally valuable states into roles designed to take care of you in an environment, in a culture where you're subject to harm so often. So, and we see more of that in the next clip. And yes, we are also seeing more of the grief and the fear too in that last clip.
Yes. I think it's good for us to go on into the next clip.
Great.
but for me personally, I mean, what just came up was keeping that awareness of the real and sometimes we'll say very present danger.
Right.
It keeps me guarding myself.
Right. Okay.
And keeps me reminded that I do have a right to feel safe. I do have a right to feel equal to anybody in this country.
That's right. Yeah.
Well, part just laughed and said, "Hey, you just been watching too much TV. Listening to too much NPR. Watching just too much news."
So you noticed this one. So again,
because I'm surprised this is what came up today.
You are. Okay. than to be surprised that this came up today. This part sounds like it's trying to make light of it, like too much NPR, right? Trying to take you away from it a little bit. I guess, would it be okay to just ask the part what it's afraid will happen if it doesn't do that right now, and let's just be with the part that has a lot of feelings about not feeling equal and being having safety.
So the part that makes light of it.
Yeah, yeah, the part
Coming in and saying that.
Yeah,
As it clearly did.
yeah. Just see what it's afraid will happen. Because we just want to be respectful of what feels right, what feels safe to parts of you right now. In this context, right, with me, we just want to trust your protectors, right, that they know, they have some wisdom if they do.
So it's like saying, if it doesn't help me lighten up, then I find myself not really becoming cynical, but maybe also falling into the pattern of otherizing others, like people who, for whatever reasons, do see the world very differently than me, or maybe would never agree that I have those rights.
That you have
the right to feel safe, the right to be equal to anyone. If this part saying, I hope you lighten up about how intense it feels. I have a tendency then to get real cynical and lump everybody together as, all boils down to, like, white supremacy is at the helm of all of it. And I know, part of me knows that there are, I don't want to do that. I want to know that, I want to believe that there are people who, their own experience brings them to this place.
right.
Why they see the world differently, why they even see me differently, or someone like me. So it's like this part just wants to say, just settle down a little bit, just lighten up a little bit, and try to not lump everybody into this big evil world of white supremacy that's out to take us backwards.
Okay. So it's like if this part doesn't come in and kind of make light of it, I'm just watching too much NPR, then you could really feel a lot of the.
And that's why this came, I'm surprised that it came up. Obviously with a lot of emotion. For this part saying, just, I'm here to help you lighten up.
Yeah.
Stop crying or stop feeling so intense about it, and I can help you just not get cynical. And
so that's one thing. Get cynical in terms of parts of you feeling like there's nothing that can be done, right? White supremacy is at the helm, and this is just going to get worse. And is it also trying to help you not feel as much fear and grief about it too, or?
Well, yeah, because that part is real.
Yeah.
I mean, that piece of the story, that piece of reality in our world today is real.
Right.
It's a threat to me.
Right.
Everybody.
Right. So it makes So does it make sense to you that this part kind of wants you to lighten up? Don't focus on that too hard. You can get stuck in that and then just feel cynical and like nothing's going to shift. Is that, and more stuck in the danger? Is that,
Yeah.
am I getting it right?
Yes. And additionally, not in my nature to want to hate anybody.
Right.
But if I get cynical and if I get just so overwhelmed with it all, then I have to push other people away.
Right. Okay.
And
yes.
then I'm the one who's also demonizing somebody else. And I don't want to be that way.
Yeah, I hear that this part in particular really doesn't want you to use the word otherize people, right? Really doesn't want you to get hardened, right? And then just judging other people.
Right.
Want you to be curious.
And it's hard to be curious about people who can, if you're watching it on TV, can be saying the vilest things about
right.
the you that's me, but collectively.
That's right.
Everybody like me, everybody who gets otherized in this country.
Right.
Because it's not just about me being a black woman, it's about so many ways people just right now are getting are under the threat of politically being valued less. So anyway, I don't know.
So yeah, just taking a moment and just this part knows that there are parts of you, and again, tell me where if I'm getting this wrong, knows that there are parts of you that when there's so much pain can feel like othering, right? And it doesn't want you to go there. Is that okay?
Do you want me to start, Enos? I want to see if you,
Yeah.
do you need anything from me? Or just a little space? It's so evocative for me too.
I'm really okay. It's just in all honesty,
Mm-hmm.
over the last several months, I feel more endangered than ever.
Mm-hmm.
I think that's
Right.
I think that's what's so hard about watching it again today.
Mm-hmm.
It's more real than ever.
Right. I was just thinking that because we've watched it a few times, and it's like every time I watch it, I'm just really freshly with so much pain and being with you and yours and fear.
Mm-hmm. And then I have another part that is even now saying, oh God, you got all these people on here who are probably wondering what on earth does this have to do with treating people with eating disorders. And there's so many things that aren't being shown right now, but lots of parts came up as we went through this whole session that truly were parts that have been around me for a long time, and we're never directly addressing all the things that impacted my relationship to food, and things that impacted my body image and created a lot of body dysmorphia and things like that. But these are parts that have been functioning all my life.
Mhm.
So there's
Absolutely.
that part that's saying people are wondering what on earth does this have to do with
Right.
eating disorders or disordered eating or ways that
Right.
relationship to food and our bodies can be injured. And that
And it,
goes way back with all these parts that we um,
mhm.
really touched on.
And but yet this is exactly the reason why we wanted to do this, because the way that we really each of us relates to food in our bodies reveals if we pay attention, those relationships, the food and body, will tell us a lot about how somebody's been hurt, either the ways that they've been hurt or the ways they continue to be hurt
Yes.
and traumatized. And so this conference is an invitation to go beyond or past the superficial and to really get to what's going on with somebody. What did their parts have to do to try to take care of them, and why? And
Yes.
so I feel like this is so incredibly valuable, um as a piece. First of all, it's so generous, right? It's generous, it's brave. I think it's really to the point, right? That we could, this was an initial session, and if we had more time, we'd hear more about how this trauma that continues today, that continues to require the continued mobilization of protective strategies. We'd hear more about the different protectors and maybe some that related more to food and body. But this is where the, the real issue is, in my view, and in
Yeah,
others' views, I'm sure.
absolutely.
And I hope it's okay. I'd like to speak to something that comes up for me every time here. Um, I'm sorry, but it moves me every time, which is I'm not sorry it moves me. It just slows me down. I feel like this piece right now about being with the protector that tries to bring in some levity so that you don't get calloused or cynical because it's not in your nature, right? That it's not who you are as a person, to want to other and be hardened and be cynical. And yet when we are being traumatized, right, and there's not an acknowledgement of it, or there's minimization of it, or there's no end to it, it's it's impossible, right? It feels just so unfair that there are going to be parts, other protectors, that's part of our protective polarizations, other parts they can't help but at times feel like othering or being cynical. How can they not? It's just a different way of protecting. And so there's just apart from self, we talk about, self isn't always calm. Self is sometimes just clear about the outrageousness and the harm. And in this case, when I watch this clip with you, I feel the pain of parts of you who really don't want to have to be holding any of those feelings, you know and so
Absolutely.
and appreciating this part who brings in some levity. Yeah.
Yes. I end up
Hmm.
telling you when you ask me how I feel towards her, I end up
Hmm.
telling you that I really like her. She's
You do.
she's been around
Yeah.
a long time and she's hilarious and witty and
Hmm.
uh, often shows up. People in my life say things like, "Oh, you could have been a comedian," because
Right.
that is very much the part that can,
Hmm.
I guess, help me push forward and do the things I
That's right.
have to do. So
And thank you for that's exactly where we wanted to name that. That's where we shifted after this clip. What we did was we got to know there was a choice point. And some people might have said, there's so much pain here. Why not go with the exiles? And what I instinctively understood from being with you, Enos, is that this protector who's been working so hard to to help you out in this awful dilemma is that says, "Oh, you just watch too much NPR." You called her hilarious girl, the hilarious one. She deserves a lot of respect, but also a lot of curiosity. If we had tried to go towards the protectors, I'm sorry, towards the exiles and their pain, my sense is that she wouldn't have been hurt enough And indeed, she had more to tell you. She needed to be appreciated by you, I think. But also she had more protectors that she was connected to. And so
Absolutely.
we got to learn more about those next.
Yes. And I think for this audience, it is so important. I want to just actually say that there was really great feedback from Angela when she watched the entire session. Just great feedback about that. Reminds me that, you know, I'm so grateful that you didn't just try to have an IFS session that went to the exile and all that good stuff we all learned, but in fact, how deeply,
Yeah.
how very deeply you witnessed. And, you know, Angela points out that,
Yeah.
you know, it's most likely my exposure and my, you know, long history with working inside of the whole IFS model that, and maybe my own self energy, my own self that allowed me to, you know, be as open as I was and allow myself to be witnessed. But I'd say to this audience that I agree with Angela that that is not necessarily going to be this straight and easy road in engaging with, you know, becoming really culturally aware, culturally intelligent, and sensitive in engaging someone whose lived experience is very different than yours. You know, it's been brought out that the majority of clinicians, for instance, are going to be, you know, white people that are engaged in providing care, as maybe more for people of color and otherwise groups are being able to step into getting help. But, you know, Angela boldly pointed out that no one should expect that this is what might automatically happen, because trust is such a huge piece. And we, you know, we talked about, I think it was Mimosa who brought up, you know, the historical situations where there's so many reasons why, as a Black person in America, I'm not going to automatically trust. And so, I guess I'm speaking to this whole audience that there's much, much that, and I'll speak to Aaron's presentation, that bringing your own level of willingness to just create a platform for creativity and that extends the possibility of really coming in relationship, building relationship, just by being willing to be so curious and so willing to just stay with it and bear witness, and build relationships that aren't automatic, and take probably for any clinician to be really checking in with their own parts, their own potential biases, their own even maybe disbelief or minimization to how very real and present, even in this situation, that danger really is for me, which is very different maybe for other people in this particular time. I'm not sure what time it is, but I feel like we're running out of time.
We are, but I think we have
Enos and Jean, we're not going to worry about the time. We're going to continue once we finish the clips and your dialogue, your processing, then we'll stop for a 20-minute break. Then we'll adjust the schedule. We'll do all the question and answer, because I know there's people that want to talk during the panel discussion, if that's okay with the two of you.
That's perfect. And I know Angela's been very helpfully adding some of her great comments in the chat, so people can get started, like percolating, thinking about some of these things. And I'm glad we'll be able to speak more later. we knew it would be a challenge to get this in an hour, but thank you for that. Okay. I
Yes,
think we do have one clip left, right? I think so.
I think so. And I think that
There's
is
one or two, but we'll get it
Okay.
all in.
All
No
right, good.
worries.
okay.
Thank you.
It just reminds me of that real potential.
Well, there is a real potential that given that we can't fix.
And all these parts are related to where we started today.
Of course they are. They're all, they are.
Now that I think about it.
Yeah, and tell me what.
They're just the fact that earlier we were speaking about the craziness going on in the world.
Mm-hmm.
Can you fix it or not?
Mm-hmm.
What your part can you do to help move the world in the right direction, whatever that means. But you gotta lighten up. And the dilemma is that there is a real potential danger, even to me personally, if things don't
Right.
go in a different way. I just see that I'm just learning a little bit about these little ways inside of me.
The question I have is there a way of being with your own needs and your own pain at the same time that you're aware of and care about others? And I'm wondering if these parts knew that there was a way that you could do both. If these very hardworking parts might be open to easing up just a little bit, or even just in certain situations. Like now, like would they give us some room to be with the parts of you that are in pain? And that may not feel right to you right now. Just whatever makes sense. Because even getting to know these parts today, Enos, is an important thing.
It feels important. It feels like nobody's giving up. We're just are giving in. We're just figuring out how to work together to balance me.
Right. When you say giving up, meaning, what do you mean by giving? Nobody's giving up, like?
I guess it seemed like everybody just said they are not feeling like I'm asking them to go away.
Oh, great. Okay, good. Right.
Be who they are, and but we're all able to work together to balance this thing out.
Yeah, that's
She said, because you're getting too old.
She's good.
She said you're getting too old to keep doing it this way.
She's good. Yeah.
Don't wear yourself out when you can just probably.
Yeah. Yeah.
I can just probably carry on.
Well,
But with
yeah.
balance.
Yeah, with more balance and support for your own pain, right? So she's great, right? She does have a wisdom about her, right? And so I love that you're not. They all feel like they have a place at the table. They all have had
really just became a table right in front of me.
It's great.
Mental and emotional eyes. It did. It was like
it's great. And Amos, I know this may not be something that they feel ready to do, but is there anything they've been carrying that they'd like not to have to carry, or try, or experiment with not carrying, just kind of laying down, maybe putting in a box or outside. Any beliefs or feelings? You can always take them back.
nobody feels alone
Fantastic. So that's something they're ready to not carry, the sense that we have to be vigilant and just stuck in our own on track. Is that like we've got more help here? Okay.
So like she doesn't want to carry all the answers. She doesn't want to carry any guilt.
Great.
Yeah, she said she's just hanging out and paying attention.
Yeah, I love that chick.
I do too. I do too. Yeah.
And that was the last of the
Yes.
video. So you were correct. Thank you.
Yeah. Mm, you know, technically just a couple of things where, you know, we talk about unburdening the exiles, but one of the things that's really, really important is, and then I'd like to talk about this later too, in terms of accessibility and also just some of the cultural legacy burdens that can be applied or kind of drive how people do the IFS model, where they have this idea, I have to get somewhere, I have to get to those exiles. That is the most important thing versus actually befriending the protectors and establishing relationships with them and helping them unblend, especially again when they're being currently called to do their work because there's current danger, there's current threat. Being able to establish more relationship with them and help them ease up a bit and lighten up a little bit. They were each willing, you know, so you just described how they were all, they didn't want to go, you weren't going to make them go away, which is important, but each of them were willing to let go of a little bit of their strategies and let you lead a little bit more. Is that right? That was the
Yes. In fact,
experience. Yeah.
at some point, it was like everybody was saying, well, I want to be on that committee to help us get some more
Yeah.
balance. And
Mhm.
so, absolutely. I also want to speak to the things that Dr. Leslie Williams brought out. And, you know, I'm just really thinking about how, in terms of legacy burdens, just so many things that I can see where I've needed this kind of help in my system to manage all the crazy. You know, was just really resonating with the story that she told about M, and just many things in my upbringing that were similar to just being badgered about things that today I know were not real for me. They were just craziness being forced upon me. But anyway, at the end of the day, I'm so grateful.
I love the anyway. I feel like we saw your part peek in a little bit. I like her so much. And we need our parts, right?
Absolutely.
We need them. I have a part who says anyway. A lot.
Well, I want to thank this whole, you know, this whole village who's here today.
Me too.
So I know you didn't know what you were
Thank
getting
you.
into, but thank you all who've been willing to come into this session and explore all of this with us. I kind of angled my camera a little bit better. If you can see behind me on the wall, it's a very treasured picture. It's I was probably 35 years old before I ever saw any representation of a Black angel. So this was gifted to me by someone very special in my life. And it's a Black angel. She's on the highway in her little short jumpsuit or something like that. And she's got these wings behind her and she's hitchhiking on a road, very much on some kind of journey. But she really helped me get through this.
Mm,
And she's right there behind me. And then there's an angel in
mhm.
this little bookcase here too. So anyway, for everybody, I'm so grateful. And we'll, I guess, have
Yeah,
some discussion later during the panel.
this, that's right, Bethany. And Enos, thank you to you, really. You didn't know what you were getting into maybe fully either,
I really did not.
Yeah, yeah.
Mhm. So
Mhm. So Bethany, are we speaking a little bit later, or are we taking some questions now?
Yeah, so what we will do now is we will take a 20-minute break.
Right,
Give everybody a chance to breathe, stretch, grab some
right.
food, really
Mhm,
digest some of the really important and helpful and vulnerable information and support that we've
mhm.
received.
Right.
So thank you so much, both of you, for your vulnerability and your openness and just being willing to share with us
Mhm,
because it can be easy. And so I think you're making us all better clinicians and better people.
mhm.
So,
Thank you.
uh,
Thank you. Mhm. Thank you,
so for everyone.
everybody.
Absolutely. So what we will do is we will take 20 minutes now. As a reminder, do not log out.
Mhm.
Just
Okay.
stay logged in into the Zoom because otherwise it may affect your CEs. But we will take 20 minutes now and we will come back. It's going to be 5:40 my time, but for you guys, what's 20 minutes from now in your time?
it's 2:40 Central
2:40.
Standard
Okay.
Time. And I
Perfect.
know
Okay.
Dr. Erica is up next with her case study.
Perfect. Yeah. So we will go right until 3 o'clock, then your time for a break, 4 o'clock my time. And look forward to hearing more from you guys.
Thank you.
So much. Welcome back, everyone. Hope you enjoyed a few minutes of decompressing, maybe eating something, using the restroom. Um, Now we are going to take the next little chunk of time for Erica Taylor. She will be sharing more about treating complex cases in marginalized populations. So as soon as you're ready, Erica, if you want to turn your camera on and take yourself off of mute, we look forward to hearing from you.
Hello, everyone. Welcome back. Hopefully, you all got a little bit of rest, got to take care of yourselves, and just want to thank Enos and Jean for an amazing demonstration of IFS. That was so powerful. And I really just appreciate your transparency, your openness, especially in light of everything that's going on today. I think a lot of people watching, I know myself included, can totally relate with some of those experiences. It's all good. Um, can relate to some of those experiences that you've had, Enos, and I'm just forever grateful that you were able to share your journey and just allow us to bear witness to some of the things that you've been experiencing so that we can learn from you, but also be more sensitive in terms of the populations that we're treating day to day. So thank you so much for sharing yourself with us. What I'm going to do before I get started, so you may have heard of my bio, and for those of you who are just joining, that is okay. Maybe you didn't hear the bio, but at the end of the bio, it was mentioned that I am a yoga instructor. And just because of the heaviness of this, of today, I just wanted to offer for us, you may want to go ahead and stretch. Maybe you did that during your break, but I want to offer just a couple of cleansing breaths if you don't mind. So maybe you could just get nice and comfortable in your chair or sofa or seat, wherever you are. Go ahead and plant those feet. Allow the ground to hold you, allow your chair to hold space for you. And just go ahead and close your eyes gently, or maybe you want to keep them open, whatever you feel comfortable doing. I'm going to close my eyes because that feels comfortable to me. And as I guide you, I just want you to take a deep breath taking sips of whatever it is that you have been receiving from this day, from the conference as a whole, holding that in your heart as you hold that breath. And then slowly exhale, sighing, letting go, releasing anything that doesn't serve you. And a couple of breaths just like that, again, taking in a nice deep breath in. And maybe we're taking in love or patience, bravery, courage, whatever comes to mind, whatever you're needing, holding that in your heart, allowing it to circulate in your body. And then slowly exhale, letting go, releasing. And maybe one other deep breath in, taking whatever again you need, holding that breath at the top. And then slowly release, exhale. And when you're ready, you can join me back, and I will be going over a case today. Actually, adjusted things just a little bit. I'm going to go over one case that I think we'll all really learn from. Give me just a moment as I try to share my screen. And I have to apologize. I lost my voice a little bit. I am based in Durham, North Carolina, and North Carolina is beautiful. It's lush, it's gorgeous, but we have pollen, so much pollen, and it's beautiful, but everything is neon green right now. And I can barely talk. So that is why I'm hoarse right now. It's because of the pollen. So bear with me. All right, I think I got it. Trying to do the. Okay, can everybody see? Thumbs up. And I can't see the chat. Let me see if I can bring up the chat. Oops. All right. We're good. Yay. Okay, wonderful. All right, so we're going to do a deep dive into a case study. And it's hard to do this following an IFS session. I'm just going to be honest. Maybe we should have flipped the order. It's hard to follow that, but I'm going to try to get us on track with this case study today and really treating a complex case in marginalized populations. But before I do that, just want to tell you a little bit more about myself and my role. So I am a child, adolescent, adult psychiatrist. I have been in this field with eating disorders for about 15 years now. I first was interested when I was during my residency and fellowship program at Duke. Go Duke, by the way, we're in the Final Four. And during that program, I decided to do an elective in eating disorders. Just for many of you, you may not realize that most physicians do not get training in eating disorders. So I could relate a lot to what Dr. Leslie had to say earlier during her talk, because there are a lot of things that I learned in medical school about BMI and about weight and about eating disorders that I really had to unlearn um, over time, being a practitioner in this field. And I progressed after I worked at Duke in my residency and fellowship training. I also stayed on for a year, excuse me, working at CAPS, the Counseling and Psychological Services, where I worked with their eating disorder treatment team and also worked with Black women, created a group with one of my colleagues for Black women who are struggling with body image distress. Did that for a little while, and then I worked at another institution that was a brand new hospital that was just starting in Durham, North Carolina, that was aimed at treating individuals with eating disorders. And it started as one tiny little unit, mainly working with college students, and it quickly grew. I became the medical director of their child hospital, and we saw all different levels of care from intensive outpatient all the way up to inpatient. And that's when I really was able to just learn a ton about individuals with eating disorders and treat diverse populations in that setting. To Mimosa's point earlier, I was one of very few. Actually, I think when I first joined that organization, I was the only person of color in leadership. And when you look at the numbers, it's not a surprise because we really only, people of color, particularly Black psychiatrists, only represent about 3% of all psychiatrists. So you can imagine that the number of Black psychiatrists in the eating disorder space is even lower. I could think of about 4 on one hand, including myself. So all that to say, I got into this field, and it was during the pandemic that I decided I wanted to do something more, really advocate for those who are typically unserved and underserved in the eating disorders community. And I joined Project Heal, gave a little plug for that earlier, put it in the chat. But it's a nonprofit organization that's really geared towards breaking down barriers to care for those with eating disorders, especially for those in marginalized populations. And it was during my time on the board that I met an amazing woman, Joan Zong, who's going to actually join us for the panel later on. She will likely share about her personal experience with the eating disorder, but she saw that there was such a need to provide more care to individuals with eating disorders, especially those on Medicaid and Medicare, those who are underinsured. And she really wanted to create a program, a virtual program that could really target individuals suffering from eating disorders from the comfort of their own homes. And that's where Arise was born. So I was really honored to be a part of this startup organization from the very beginning, and helping to really think creatively about how we can just treat our members, how we can think about other solutions besides the usual, because we know that FBT can be really helpful. We know that CBT can be really helpful, but there may be certain individuals where it's actually not helpful and it can be harmful. We wanted to really think outside of the box in terms of how we could really target the people we were trying to see by utilizing a lot of different treatment modalities. And I was so grateful that she gave me a lot of bandwidth and freedom to really explore. And one of the things that we came upon was IFS. And what was cool is that they had a conference last year that I was so honored to be a part of. And I invited the entire clinical team at Arise. I mean, we had dietitians, we had therapists, we had, primary care providers, psychiatry represented, and we took up a whole table at that conference last year. And I really am so grateful. I want to thank Teresa for, inviting us and for including us, but also for talking about such difficult topics in the eating disorders field, especially at a time, especially now, where equity is being targeted. And our history sometimes, as people of color, is, people are trying to get rid of our history, and trying to erase it in some ways or another. So I'm really grateful and appreciative that we are able to have this space to even talk about, to have the conversation, right? The courageous conversations about treatment, and, cultural humility and curiosity, and all the things that we've been discussing today. So I want to tell you a little bit about our approach, because at Arise, we're really trying to think outside the box in terms of ways we can, provide treatment. And IFS came up. We went to the conference. Like I said, we were all represented there, and it really was amazing to just see the light bulb come on for just not only me, but so many of our treatment team members. And they were really excited because IFS seemed like an approach that was destigmatizing, really putting the client at the center, really acknowledging that they are the expert of their own care and their own journey and their own healing. That, yes, we have our expertise, but we're really coming alongside our members to help them along their journey of healing and really following their lead. So for us, it was really important to provide person-centered care, trauma-informed care, and really, again, putting the client at the center of everything, and really empowering them to feel as though that they can get the care that they need, and that we're just along for the journey to help them get to that place. So I wanted to share a little bit about a member that we treated at, really, she's been in our care for about a year and a half now. We'll call her Bianca. I've de-identified her information just because it is confidential information. And that's also why I did not share my slides. But I wanted to just tell you a little bit about a young person named Bianca. So Bianca is a 38-year-old queer Latinx person living in a larger body. She had multiple diagnoses: binge eating disorder, PTSD, major depressive disorder, OCD, ADHD, substance use disorders, and later on we would find out DID. She also had a lot of trauma, so neglect during childhood. She was sexually assaulted at the age of 4 by a religious teacher. And then again, at the age of 10, she was molested by her fourth grade teacher. Between the ages of 18 and 19 years old, she was sexually assaulted by her ex girlfriend. By the age of 20, she was assaulted by a male and became pregnant, later giving up that child for adoption. And she also did sex work during the 20s, and who knows what kind of trauma she was exposed to during that time. She also came to us with a lot of grief. During our time with us, she acknowledged the death of her grandmother, and her grandmother is actually the person who raised her, despite the fact that she lived with her family. Her mom and her dad were in the home, but she essentially was raised by her grandmother. As I mentioned, she gave her son up for adoption. Her ex girlfriend died by suicide. She dealt with a lot of barriers, financial barriers. In her family, there was definitely food insecurity. There was a lot of neglect, physical abuse as well. And she also was recently unemployed. She had a lot of negative interactions in the past with clinicians and a general mistrust of the medical system, as Dr. Leslie pointed out so eloquently in her presentation. She had a lot of mistrust towards the medical system and her clinicians. Um, in terms of disordered eating behavior, she essentially experienced a lot of binge eating disorder, but I think binge eating behaviors, excuse me. But I think what was often overlooked, especially because she was living in a larger body, a lot of times the restriction was overlooked. So she indeed did experience restriction as well as hoarding and hiding food, which actually began at the age of 2. She had experienced a lot of hatred towards her body and had been through a lot of weight loss interventions. Additional presenting symptoms included skin picking, depression, dissociation, suicidal ideation, and also a lot of avoidance, nightmares, and other post traumatic stress symptoms. So I want to just pause here, and this is a time when I know we've all been very comfortable. And, I'm the queen of multitasking. So I'm sure you've been off camera doing all kinds of things. But this is when I'm going to ask for you all to maybe be brave. Maybe if we can have a brave space, and I'm going to give another shout out, as Mimosa did, to Dr. Jenny Wing Hall. She talks about creating brave spaces because, as Dr. Jean mentioned earlier, we can't guarantee a safe space for folks. That's all relative. But what we can do is create a brave space. So this is where I'm going to depend on you. And initially, when we thought about this session, we actually had planned on there being smaller groups and breaking you out into groups on Zoom, but there's so few of us here that I figured it'd be nice for us all to join in on a conversation. So you don't have to, but I'm going to ask if you can maybe show your faces. I'm going to ask a couple of questions, and I would love for us to participate. You can put it in the chat, but you can also unmute yourself and share what's coming to mind for you too. Okay. So, are we feeling brave today, y'all? Okay. I don't hear you, but that's okay.
Yes.
So, yes, all right. Thank you. So, what are some social and cultural considerations when you think about this person, whether from a therapeutic standpoint or from a nutritional lens? There are doctors, physicians that are here, NPs, social workers. I think every kind of clinician is represented today. So, what are some cultural and social considerations that you're thinking about that are already coming up as I present this case to you all?
My first thought was what complex trauma she's experienced. With the layers and layers and layers of trauma throughout her life. It's just, we can't not observe how complex that trauma is. And probably the degree to which a lot of it is like a legacy trauma from her whole family history.
Absolutely. So, epigenetics, right? What are we carrying in those telomeres, right? In terms of trauma, but then also, yes, to have experienced the trauma. If she was hoarding food by the age of 2, you can only imagine what kind of trauma she's been experiencing her entire life. Yes. Monique, I can show the profile again. Oops. There you go. So yeah, she's experienced a ton of trauma throughout her life, a lot of grief as well. Losing her grandmother was powerful, because again, she was raised by her grandmother. So while she was with us, it she was approaching, I believe, the 20th anniversary of her grandmother's death. So that means her grandmother, if she's 38, then it means her grandmother who raised her passed away around the age of 18, when she was about 18. Any other things that are coming to mind? Just considerations. I love this. I'm seeing a comment in the chat. We can't make assumptions about culture by knowing labels. Absolutely. Does anyone want to expand on that? And I guess that gets to my second question, actually. What are you curious to know more about?
Um, I think I can jump in here. I think what's really interesting, especially about our field too, is historically it's been, okay, here's this group of people, and here's this information about this group of people. Okay, here's this group of people, and here's the information about them. And we lose the context of intersectionality, and we lose the context of, okay, what is your family culture? What was it like within that family unit? What was your school culture like? What was right? And there's so many different layers and levels that we can't even begin to assume that we know. And so a lot of times when I'm working with somebody who comes in with a lot, whether that's a lot of diagnoses or a lot of identified trauma or whatever it is, just giving them that space that intentional space to share if they feel able and willing about what some of those intersectionalities have been like for them. Because I think when we're being culturally humble, we're humbling ourselves, and we're assuming that we don't know anything, and we're assuming that the client is the expert on their life and their context. And so it becomes more of a partnership and less of a, oh yeah, you're queer and you're Latinx, so that means that your family is blank.
Absolutely. Yes, I love that. And I'm so glad that you mentioned intersectionality, right? Because I think that's something that we're seeing in this case. And, when we see that there may be, race and gender and sexuality and all these things coming together, how that might impact, right, the manifestation of an eating disorder and how that eating disorder is expressed, right? And all the other types of conditions that this individual is also experiencing. So keeping that in context. But I love what you said, Bethany, in terms of, yes, how do we create that space, right, where it is a brave space where we can start to just gently ask, if what that culture was like in their family, especially in light of what we're seeing here, at the age of 4, that implies to me, by a religious teacher, this is a family that was definitely rooted in their religion and their faith. And you think about going to a place of worship and what we're seeking in that place of worship, a sense of safety, right? A safe sense of protection. But to see that she was sexually assaulted by the age of 4 in this supposedly safe space, right? And then how did the family even aware of that? How did they, what did they do to protect her? We know that there was some neglect there. Were they aware? How there's so many questions that I have. I see I think there's somebody else though who has asked the question. Oh, what is Bianca's current support system? Yes, absolutely. So she currently has a roommate and she's married. Doesn't really have that many friends, has some interaction with family, but it is a strained relationship with her family. Her main source of support is her partner. Any other questions or insights?
Hey, I'd like to elaborate on the comment I made about not being able to judge someone's culture based on labels. Sorry, I was baking bread while I was
Oh,
listening,
big,
so
I
I had to
love,
get back to my office.
I love
Um, so, to kind of expand on that, like for example, I'm actually Afro-Latina, obviously a brown person, but was raised by my white family, and that had a lot of cultural implications for me. And then also immigrated here when I was 6. So, like, just because you're Latina, like, have you ever lived in another country? Is English your first language? Like, there's lots of cultural things when it comes to like language, heritage, colorism in the Latin community, and that kind of thing. And then the other thing that stuck out to me, besides her intense trauma history, is that with hiding and hoarding food starting at the age of 2, I'm wondering, was that related to food insecurity? Or was that related to being shamed by other family members for her body weight, shape, or size, or the language she was hearing culturally within her family about bodies? Was that contributing to her hiding and hoarding food at such a young age?
Yes, thank you so much for that. And thank you for sharing your own experience too. I think it really it is in our lived experience, right? That we bring that to the table and we think about IFS being this relationship, right? So we are bringing all of that to the table. And when I love that you gave that example, because I know even as a Black woman, I sometimes am treating other Black women and I can't make assumptions about their experience, right? Especially because I have to ask, okay, are you a Black woman who was born here in the United States? Are you a Black woman who's first generation? Are you from the Caribbean? Are you from the African culture? What are these other things that culturally that may be very different? And I can't make that assumption. So even identifying as Black, sometimes I have to dig a little deep to understand, yeah, what does this mean? What were those messages like in your family growing up that may be very different in my experience, right? So thank you so much for sharing that. Chantal, is it Chantal? Okay, great. Thank you. Another question here, what modalities have been helpful for Bianca? Well, to be honest, Bianca has not really found treatment helpful. And Bianca has really not been in treatment consistently. I would say she's engaged in some treatment and found it to be just not helpful. She's been on multiple medication trials in the past and found especially SSRIs to actually make her feel worse and even suicidal, and often feels as though people are quick to medicate her. So she especially has mistrust of any kind of psychiatric medications. When thinking about Arise, for those of you who are not familiar with the program, it is a multidisciplinary program which provides a therapist, a psychiatrist, primary care, a nutritionist or dietitian, and then combines that with community care. So Bianca is also given a peer support care advocate, someone with lived experience who is able to engage with her and talk about her own experiences, and is able to choose too based on shared experiences on which care advocate would be a good fit. So I think that's what helped her to be drawn to this program, was actually more so the community care advocate component. She was actually very hesitant to engage in therapy, but was more so excited about working with the dietitian and the care advocate. Anything else that you're curious about? Okay, I'll go to the next slide. Oh, yes. Somebody wanted to know if I could talk more about the peer support care advocate. What is their training like? How do other practices use this model of care in their practice? So essentially for this program, the lead of community care is actually someone who's completed peer support training and is a coach, is an actual eating disorders coach, and has done a 2-year training and has trained many other coaches in the space. and created essentially a program specifically for our care advocates that takes a lot of the principles from the coaching and peer support world. So it's a pretty intense training program that they go through within our program. And they also receive feedback, meeting with that care community care lead on a weekly basis. They also come to all of the treatment team meetings, and they present each case before the clinical team presents their case. So you will hear from the care advocate, because we really believe in hearing from the voice of the member before actually diving into the therapy and the dietitian work and all the psychiatric work. So thank you for that question. Oh, yeah. So hopes and goals for care was really a lot related to body image. When looking at the intake paperwork, a lot of what she wanted to get help with was body, accepting her body and not hating her body as much, and not hating the fact that she would engage in these binge episodes, not feeling the shame associated with that. There was a lot of internalized shame and guilt associated with the binge eating, which then ended up leading to restrictive behaviors. So my next question, before I dig in even deeper on this case, what are some messages, and this is based on some of the things that you've been hearing from today and yesterday here at the conference, what do you think may be some of the messages that this individual may have received from society, maybe from her family, or maybe even her treatment team? It's all in your head.
Her
Absolutely.
family is Catholic, as a lot of Latino families are. She might have had a lot of like judgment and criticism about her sexual orientation and her sexual behaviors.
Yes, absolutely. Thank you. Yep. Yep, it's all in your head. You're crazy. You just need to pray, right? So sometimes, and that's something, again, we wouldn't necessarily want to assume, but these may be things that we're wanting to know more about, right? This piques our curiosity to ask a little bit more about what were those messages that she got from church, particularly relating to sexuality, right? And relate, especially because of her sexual trauma. Needing to pray. I've also worked with, not in this case particularly, but I've definitely worked with individuals before where it was frowned upon for them to even engage in psychiatric treatment, that, they needed to actually pray, and that, depression or anything like that is from the devil. If they were experiencing any kind of internal turmoil, that comes from the devil, and that they would need to, pray it away. They need to read the Bible more, a lot of shaming for even seeking psychiatric and mental health services. So that's also something that, I would want to explore. Ooh, treatment team. Yes, you need to work harder and be more treatment compliant. So that is so powerful, Mimosa, because that was something that I think we all as clinicians have had to unlearn, right? In medical school, when an individual did not take their medications consistently, they were deemed to be medication non-compliant, right? I'm giving an order. I'm telling you, you need to fill your prescription, that you need to take it as I prescribe it, and that when you are not following my directions as your doctor, then that means you are not compliant with my recommendations. And that is something that we learned from the very beginning, that I had to literally unlearn, right? And actually remove that word from my dictionary, right? Treatment compliant. Another word that comes up, I think, often, especially in eating disorder spaces, is manipulative, right? Oh, they're engaging in self-harm, they're being manipulative, right? They're trying to get us to see that they need more time in treatment, or that they, whatever we may decide, but that language, right, brings some sort of fault that they are doing something wrong, that they're not engaging in their treatment in the way that they are supposed to. based on standards that we have set and guidelines that we have set for them, right? And then they may even internalize that, right? And I think Dr. Leslie shared that earlier, that when they're being, not being treatment compliant, i.e., my doctor has told me that I need to lose weight. And if I'm not doing that, then it means I'm not being a good patient. So why would I even go see my doctor? Because I already know I gained some weight and I know what they're going to say. So I'm just going to go ahead and skip this appointment, right? And that leads to not getting the treatment that we need in the time that we need it. Oh yeah, appropriate. Also in the word inappropriate. Yes. Can you expand on that more, Jean?
I feel like when people are in treatment, their behaviors or their strategies get described as it's inappropriate, it's too much, it's too little, excessive, whatnot, instead of considering in context what's happening. It's such a
Yeah,
judgmental word, right?
it's
Instead of
so
curious about what's happening. Hmm.
absolutely. And that's why IFS really resonated with us as a team, Jean,
Hmm.
because um, instead of those behaviors as being like, disruptive or like you said,
Right.
too much or inappropriate, um,
Hmm.
that we were able to view them in a different lens, right? That,
Exactly.
okay,
Yeah.
these behaviors, rather than, you know, um, saying, okay, this person is doing this because they're being manipulative. It's like,
Exactly.
actually,
Right.
maybe they're doing this because they're being protective,
Exactly.
because they're living in this society that deems them as worthless, right?
Right.
Especially now post-election. And that's why what you said, Ines, really
Hmm.
resonated with me, because I'm seeing the threats and the danger daily. And I know I'm not the only
Hmm.
person. There are literally people I
Hmm.
talk to on a day-to-day basis who are fearful for their lives.
Yep.
And especially
And
in terms of resources,
yes,
to just see resources shrinking and shrinking for people to obtain basic medical care, let alone psychiatric medical care.
Yeah.
Um,
and even beyond care, people are losing their jobs. People who were
yes,
promised jobs are now having jobs rescinded, and to not know how you're going to pay for your rent, to not know how you're going to pay for food. These are real dangers that people are experiencing.
Hmm.
And when you're seeing that, okay, people don't care, people don't think that I'm worthy of these programs, or of assistance, then
Right.
I start to internalize that based on what I'm seeing day to day. So yeah, so I think all of that, I think when I think about this individual, I'm also thinking about it now in that context as well. But this is an individual who's heard a lot of these messages. They're living in a larger body. So they, of course, have heard from their doctors that they need to lose weight. They've heard from their families that they need to lose weight, that they need to watch what they eat. They've been blamed for, engaging in binge eating behaviors, eating food late at night when people are not awake. And then food is gone, right? Food that the family needs is gone. So who's going to be blamed for that? This individual who's been binge eating in the middle of the night. So they're experiencing that. They're having the weight stigma that they're experiencing in the medical field. They're internalizing that. They're being told that, they're not treatment compliant, that they're not really serious about wanting to get better, that they're not perhaps if they took it more seriously and they actually engaged in treatment and stayed in treatment, perhaps they would be recovered by now, which begs the question, how do we even define recovery? What does that look like? How are we defining that for our patients and our members and our clients? Sorry, I'm a physician, so I say patient all the time. That's 20 years though of saying the word. So how are we, you know, just internalizing all of these messages and then going to a treatment team, knowing that we're probably going to go through the same old again. And I'll have to say, at the very beginning of her treatment, despite all the intentionality of what we were doing at Arise, we were approaching her with some of the evidence-based treatments that we know to be helpful and useful, which are CBT and DBT. And what I can tell you is after about 3 months, not 3 years, oh my goodness, 3 months of doing CBT with our team, she completely disengaged from therapy. She still was meeting with her dietitian. She found meeting with the dietitian was helpful in giving some structure to the for the meal plan, because that helped to alleviate some of the binge eating. But there was a lot of binging that was happening in the context of dissociation. And that dissociation was happening in the context of her trauma that was just undealt with. So we had been tracking along doing CBT and, some DBT grounding skills here and there. And then the whole team came to this IFS conference last year. And we all were like, okay, y'all, why don't we approach this patient, this client in a different way? Let's see if we can really do some parts work. And I have to say, the treatment team started to do some amazing and just beautiful work with this individual, really beginning with just creating the space to listen. And we talked a lot, Ines has talked a lot about witnessing, right? What does it mean to witness? When you look that word up in a dictionary, it means to see, to hear, to be present with, right? And part of it is, how do we just back up and take stock and just listen? What has worked and what has not worked? We actually did switch her therapist to the therapist that actually attended the IFS conference. And that therapist decided, I'm just going to take some time to listen what's worked in therapy, what hasn't worked, and was able to build an alliance and a common ground to say, okay, now that I'm aware of that, I just want to be here with you, and what are your goals for treatment? You don't want to experience the shame. You don't want to hate your body. You're experiencing dissociation and missing things. You're not engaged with your partner, so there are things that there's more intimacy that you desire, but you're not able to have because of your trauma. So let's work on those things and let's see how the eating disorder is involved in all of those things. So the therapist was able to really sit with the member and just provide the space, a brave space. Um, the other thing, and yes, is my client being seen by me? We have to be able to pause and ask ourselves that when we are feeling, and again, I don't want to use, I hate the word resistance, right? That's another word that shows up in our language, right? As eating disorder specialist, this person is resistant to treatment. Is it that they're resistant to treatment, or is it that we're not providing the right treatment for that individual? Is it truly patient-centered care, person-centered care? So when we see that we are not making progress in the way that we would want to see, we do have to pause and say, is this person being seen by me? Are there barriers here in this room, in this virtual Zoom room, that I am unfortunately putting up that is preventing this patient or this client from being true and being open and being free in the session? So that was a huge, huge part. The other thing is then the team started organically learning more about the parts that were coming into play. And the part that usually was deemed as being the aggressive, the rude part, or, the individual who was resistant to treatment and non-compliant, we realized that was her young adult part showing up. And that part was in her 20s. That part was really angry, really resentful, really irritable, extremely self-critical and mistrustful, and really wanted to be in control. This person did not want to have other individuals, and especially adults who claim to be experts in things like, eating disorders, to run the shots. This person wanted to be in control. And why? Because this person was very protective. So when this person started coming out in treatment, they also started to unravel another part, which was the child part. This was a part that still felt very unsafe, felt very scared, felt ashamed, particularly of the binging behaviors. And the young adult part was able to kind of show up on behalf of the child part. There was still a lot of exploring that needed to occur with the child part that this teen part, I mean, excuse me, that the young adult part was very protective of and didn't, and almost afraid to allow that younger child part to be present in sessions because she was afraid of what more may be in those layers of trauma that were somehow forgotten or somehow overlooked. So what was really cool, and again, I have to give credit to this team because every week in our treatment team rounds, they were able to talk about the parts that were showing up. And sometimes the adult part would show up with the dietitian, and the child part would show up with the therapist, and vice versa. And what the team was learning how to do is, how do we now integrate these parts? There was a time in her treatment, maybe about uh, 6 months after we started the IFS work, that a teen part started to be revealed. And this teen part really minimized everything. It is what it is. It's whatever. Doesn't matter. And that teen part was kind of like, okay, we just accept things as is. We don't fight. We just allow it to be. It is what it is. And that's a means of survival for us. So they started to see these parts show up. And interestingly, certain parts started showing up with team members all the time. It was like the psychiatrist, the psychiatric MP, excuse me, was getting the young adult part. I'm not going to be on medication. You're not prescribing anything to me. I've been there, done that. Nope, 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 nope. The child part was starting to show up a little bit more in therapy. And then we started to see a little bit more of the teen part in the nutritional work, right? The dietitian's just going to give the meal plan. It is what it is, whatever. All right, just tell me what to eat. So then what the team started to do to be able to help this member better integrate their parts was to say, okay, when we're starting to see these other parts, and again, what would we call that in the eating disorder space, you all, when we start to see how people show it with one provider versus another? That can also be a little demeaning. Well, the word I'm thinking of is splitting, right? Oh, this person is splitting, triangulation, right? Which usually implies some manipulation. They're manipulating the therapist and manipulating the psychiatric MP. So we viewed it more so as, no, they're utilizing all of these parts to, again, there's some needs that are being met, right? When they're showing up as their child with the therapist, or they're showing up as the young adult part with the psychiatric MP. Why don't we meet with this individual together as a team? And how do we start to build that trust as a team? And what the psychiatric NP was starting to do was ask the young part, hey, is the young part here today? Because if so, I want to get consent from her to ask about the medications. That was another part, is listening about the medications and the side effects that oftentimes this individual experienced that their previous psychiatrist just overlooked, right? Who said this? Somebody put it in the chat. It's on your head. Give it some time, right? But no, like, they were experiencing real legitimate side effects. So now their psychiatric MP is able to listen. What worked? What didn't work? You know, what felt the best for you? And this individual said Wellbutrin. Now, as a psychiatrist, when I hear Wellbutrin for an individual with this level of trauma and PTSD, I'm like, absolutely not. I'm not prescribing Wellbutrin to someone with this level of trauma, with this much dissociation. Why? Because research wise, when you look at the research studies, Wellbutrin tends to be more activating, especially in people with eating disorders. Also, there is a black box warning in Wellbutrin, particularly when it comes to binging, purging, or any kind of electrolyte disturbances, because it can lower one's seizure threshold. So when I hear Wellbutrin and somebody who has an eating disorder, I'm automatic, no ma'am. Sorry, let's find another medication. But this individual had shared that that was the one time when they were on Wellbutrin long, long ago, they actually felt more in control. And I think part of what that may have been is because even Wellbutrin is an antidepressant, it also can help with ADHD types of symptoms. So perhaps this medication allowed them to be organized enough to even sort through their feelings and to be organized enough to eat meals when they're supposed to. And, all the things that you think about how ADHD can complicate all the things that we've already seen for this individual. So we were able to come up with a plan for this individual to just be monitored very closely and to resume the Wellbutrin. But That psychiatric NP, and I have to give her so many props, did such a beautiful job of getting consent from all parts of this individual. Does this part give consent for this medication? I know this child part can't speak for herself right now. She's a child. She can't give consent for medications. Does the young adult give consent for her to take it? Here are the risks. What are we concerned about in her taking this medication? And part of it was even access. I don't know if I can afford it. I recently lost my job. Another thing that came up most recently is there's a certain individual who is now in leadership at HHS who has threatened that all antidepressants might be harmful, and that there will be some more research looking into the harmful effects of these medications. And there was a big scare amongst the psychiatric community that maybe these medications will no longer be available. So this individual, once they gave consent and they started the medication and they started to actually feel better, which allowed them to better show up in therapy because they're able to better organize and better express themselves emotionally. They were like, oh my gosh, this medication is so helpful. But now I'm worried that it's going to be snatched away by this administration. So then that was another layer that we had to work through. So all that to say, and I know, gosh, I could talk on and on about this case. But I just want to acknowledge that it's so important um, to work collaboratively as a team. And again, it's because this team was so creative and thinking about, okay, this approach is not, CBT is not going to cut it for this person with all of this trauma, all this intersectionality. We have to applaud this person for really standing up for this child part and protecting this person, and seeing even the binging as a way of protecting, the restricting as a way of protecting, right? So how, instead of making this person feel shame when they do engage in behaviors, how do we say, no, you were doing XYZ, right? So how do we help you manage and deal with these internal emotions that you're experiencing? How do we do the grounding? How do we release the exiles? So a lot of that work was being done. In addition to some grounding and some DBT, and still incorporating some CBT skills, but again, right, using that creative approach. The dietitian was also able to um, see how certain parts were triggered and how those triggers may manifest in different types of disordered eating behaviors, and to really, again, get consent and to collaborate with this individual on the meal plan, and also removing the shame from some of the cultural foods that they typically may avoid, right? And there were certain foods that they avoided from their childhood that reminded them of trauma, that reminded her of a relationship with her dad that she just completely avoided altogether. So part of what the dietitian did in asking for permission to get consent to do food exposures to the foods that were triggering, that were culturally relevant, but also in some ways triggering to this individual. And then again, I talked to you about the psychiatric interventions. So I want you all to think about, in your own work, um, there were definitely some things that I think we did initially that did cause harm, and we had to sit, reflect, and press the reset button. And once we did, we were able to really approach this person in a really holistic, humanistic way, compassionate way, not telling her our way, but allowing her to guide us. And I think, unfortunately, and I know we are all coming from different journeys. I've worked at every level of care. So I've worked at inpatient. I've seen people being force fed, which is the hardest thing to see and witness as a physician, in my opinion. I've seen people be put in restraints. And when you think about that, I actually have a patient that I'm seeing now. She's a college student. She's actually a senior, and I'm so proud of her. She found me a year ago after, and I don't even remember this child's face, okay, because she's an adult. She said, Dr. Taylor, You treated me at the first hospital I was at when I was 13. I said, whoa. And she said, and when you left, I remember when you left. And she said, and I stayed at that hospital for some time. And she said, and then I was transferred to another hospital. And she said, that hospital has caused major trauma because I was force fed. And I just did not see any way that I wanted to live without my eating disorder. And I have such a mistrust of the system now. And when I came back to finish school in this area, because she actually didn't live in this area, but she came straight to North Carolina specifically for eating disorder treatment. So I came back to come here for college, and I wanted to make sure I found you. And I'm so glad I found you now. And I'm like, whoa, like, and it came back to me. I was like, oh my God, I remember this kid at the age of 13. And oh my gosh, like, one, she's alive. I didn't think she would make it, but she's alive. And not only is she alive, she's a grad, she's about to enter her senior year, and now she's about to graduate from college. So all that to say, we, I'm sure, did harm in our hospital too. She experienced harm in the second hospital, but we did harm too. And part of what I did when she came back is I apologized. I apologized to her on behalf of my profession and myself. I said, I don't remember all of the treatment interventions I did while you were in care with us, 7 years, however many years ago that was. So I apologize if and when I caused you any harm. And I want to make sure that we are able to work together as a team to collaborate so that that doesn't happen again. And she appreciated that. And it was, I think, a turning point. She is still struggling, but we are trying to get her across that graduation. Like, we are trying to get her to graduate in May, and I'm confident she will. She's still struggling with this eating disorder. She has fired lots and lots of people, and I've got fired too a couple times, but she's still with me. But I had to pause. I had to take ownership. I had to take accountability. And I want us all to just pause for just a moment. You don't have to share, you're welcome to share, but I want you to think about this question: in what ways do we, not can we, do we, because we do, as eating disorders professionals, cause harm, particularly in marginalized communities? And I want you to just sit. Maybe you can close your eyes. Maybe you can think about times that you have. And this is not to shame or blame or point fingers. This is for us to grow as clinicians, right? And to evolve. Because when we know better, we do better, right? We're not perfect, we're human, and we're coming with our own experiences. I too, I'm sitting in front of you as a Black woman, but I have a lot of privilege. I went to some of the best schools in the country. I've traveled the world. I've seen a lot. I live in a straight size body. So I'm too coming in humility, recognizing I've done some things too. And it's not to shame myself or to blame myself, but it's to grow from it and to evolve. And that's our ask today, is that you are integrating all of this information, the live session, all of the lectures that you've heard today from these amazing clinicians, and take time to reflect and to think about, okay, what did I learn? Some of this is not even our own fault. Some of this we have learned from our privilege. We've learned in our training, right? That then when we see people with lived experience and they're able to say, hey, that's not helpful, that's actually harmful, we could say, ooh, my bad. So I'm loving the comments. I definitely want to go through all of these. Thank you for your openness. Thank you for your vulnerability. Some things about this young lady: she is still in our care to this day. She is working on integrating all of these parts Some of these parts are scarier than others for her to accept and to hold space for. There's some parts that she really doesn't like, but we're helping her to learn how to have an appreciation for these parts. She's utilizing her skills. She's seeking help. There's a lot when you deal with trauma as early as that, you learn that adults are not dependable. So why would you ever ask for help? She's learning how to ask for help. She's seeing a reduction in her acute trauma symptoms. She's more present. She's more grounded. She's not restricting as much. I think the last note I read from last week, binging twice a week or less, hasn't restricted in weeks. She's open to food exposures, to the scary foods that remind her of her trauma. She's no longer engaging in self-harm. She hasn't in a long time. She's processing the trauma, whereas before she wanted to avoid, or not, maybe that she wanted to, she had to. She's consistent with taking her medication. She finds them helpful. She's afraid of them being taken away. She's engaging with all of her treatment team members and is saying for the first time she's feeling safe. So she's got some ways to go. She's got some ways to go, but I'm confident that with the continued compassion, continued curiosity, humility as clinicians, that she will find her way and we'll help her get there. So I want you to think about some takeaways, not only from this case, but the day. And I actually, I thought I had a slide here that had some takeaways. Okay, hold on. Let me stop the share. I want you to think about your own takeaways as I figure out how to unshare this. Okay. I have a slide. I think I brought up the wrong one. I'll pull it up. I want you to think about some of the takeaways that you have, write them down. And yeah, I'm so sorry. I don't know what happened. The slide disappeared. I don't know how that happened. Did I accidentally erase it? But I did have some slides of key takeaways, and I'll just tell you what they were. Essentially, the first one, and this is something that was shared at the very beginning, is research. You know, are we including marginalized populations in research? So for those of you who are researchers, I hope you are thinking about that and ways in which you can involve communities that are typically overlooked by involving them more in research. Are there ways that you can be better advocates, that we can be better advocates? So whether that's, looking at every realm of influence that we have, we are all leaders within our own spheres of influence. So whether we're in private practice or a group practice, or we work for a treatment center, or we work for a community center, wherever we may find that we do our work, we can have influence in those spaces. How are we advocating for these individuals? Are we able to go back and say, hey, I know we usually use this treatment modality. Is there a way we can get training on some other modalities? So that would be something to think about too. Are there ways that we can be better advocates by, and are you all seeing slides? I lost everything. So I
I'm
apologize.
not seeing a slide.
You don't see the slides? Okay. I even lost my view of you guys. So I
We
don't
see
know. I have
you.
my slides. You see me? Okay. I can't see you, but I'm glad you can see me. Are we being advocates even in terms of training? You all are here today, expanding your knowledge. How can we take that training back again to those of our colleagues and our peers? I had a peer just today who was a psychiatrist, and I had to explain to her, she said, why are we getting people back up to a BMI that's higher when they have an eating disorder? They shouldn't be at a high BMI. Then that's going to put them at risk for all these other things. So I had to do some explaining about BMI and how that can be harmful in our practice as psychiatrists and as physicians. Are we offering opportunities to collaborate with other clinicians of color? Again, it was shared earlier that there just aren't that many of us in the field. Are we looking to work with other colleges and grad school programs to recruit people into the eating disorders field? Because again, they may not even realize that individuals from marginalized identities actually struggle with eating disorders. So, how do we educate and how do we continue that training? How do we hold ourselves accountable by doing that self reflection work, taking the time to understand our privilege and how implicit bias may impact our approach to care without even knowing it? And it's in having conversations and it's in learning about others that we do that work. How do we advocate on a community level or beyond? Maybe we call our legislators, maybe we call our senators. Joan is really good at that. She has, I think she has her senators and everybody on speed dial because if she sees a problem, she's like, okay, let me call my representative at the state level, right? So who are you calling? Are there ways that you can be more engaged with organizations and nonprofits like Project Heal or with the EDC? And the EDC is really great at looking at policies and how policies can impact individuals with eating disorders. Providing uh, culturally sensitive care, collaborative care, and trauma informed care. How can we look at our practices and make sure that we're doing that and honoring the cultures, being more curious about individuals who may not look like us or experience the same cultures in the same way as us, even if we come from the same culture? So, how can we be more curious? How can we be more humble? So I appreciate I went a little over, but I appreciate all of you for just staying engaged and for your participation. I'm going to hand the baton over. I think I'm going to moderate the next session too, but I want to pause here. I'm not sure if anybody has any other acknowledgments before we step into the panel.
Yeah, I think unless anybody has anything else related to the topic that we just discussed, I think we're okay to transition over.
Okay. And I found my screen. Yay. I had slides. I'm like, I see slides, but I don't see y'all. Sorry. All right. So this is our time for the panel discussion. Some of you have had some really great and rich questions. But before we go into all of your questions, I would love for everyone to just do a brief introduction of themselves, and then also if you can share um, your experience, whether that is your lived experience or your experience as a clinician, and also your relationship with that in IFS. So I'm going to start with Joan. You're
Okay.
at the top of my screen.
Thanks. So as Erica has mentioned, I work closely with Erica both at Project Heal, but also at Arise. I'm one of our co-founders and our CEO, and really came to this eating disorder space because of my own lived experience with an eating disorder when I was going through college. And I'll happy to share a little bit more about this in a little bit, but I think a lot of those traditional models of treatment didn't really work for me. And I think a big dynamic was seeing my providers as almost this like God complex figure where I couldn't push back when they were recommending something that I just didn't knew wasn't going to work for me. And I actually happened to stumble upon IFS in my own just personal therapy work, and just everything really clicked for me. And this was 10 years after going through eating disorder treatment. So really excited to be here. I'm based in Houston, Texas. And since I'm in Texas, Erica knows I call my state representatives all the time. So anyways, I'll pass it over to Angela.
Hello, I'm Angela Mensa. I'm a professor at the department or in the Department of Communication from the University of Arkansas, and am in this because I was researching on body image and what I thought the problem was, which were media representations, and learned with through interviews that that was only half of the issue. And what it brought up for me were past traumas of my own that I had forgotten and buried, and it made me curious, and so I started treatment for myself. And I've never done IFS, but I I really identify with Bianca and a lot of things that she went through, and I became very distrustful of the therapeutic world because I do have multiple diagnoses, and I'm very sometimes I'm not open about them, but I try to be so people can see that basically what's happening is you're turning away people like me, and you're making people like me. Once we even want to come and open up, we feel so stigmatized in those spaces that I've learned that I'm untreatable. I mean, and that's what I've learned from practitioners, dietitians, psychiatrists, people that are well-meaning people that passed me from person to person to try to get me, some form of treatment. And I've pretty much thrown my hands up. So my way of helping is to try to acknowledge and share my story, so you don't turn us away. And like Dr. Erica did so bravely, was apologize and then was able to help that woman. And I'm just thinking, wow, that I've never heard something like that before. And so I'm so hopeful that through these types of platforms that people like us will be able to get help, and to see and witness Jean and Enos go through a therapy session is like a dream. I mean, that's for me. I just could not believe what I was seeing. It was so magical to me. And also, even more magical was to see a Black woman to be able to open up like that and be safe like that in a space and be seen and not demeaned and not, kind of discouraged, and letting those parts like come out and emerge and evolve, and she was able to bear witness to that. So I'm here, just, I don't know, a cautionary tale, and hoping that in the future that people can get this kind of treatment. I've never had an IFS session. I was leery of it, and that's, again, I'm so excited about this whole kind of movement and this platform, and I hope for the best for other people and for the future. So thank you. And I will pass it to Mimosa.
Thanks everyone. Such an honor to be on this panel with you all. And how I came into the work of eating disorder recovery was that was the invitation, right? Is that right, Dr. Eric? Okay. Um, I came into the work of eating disorder recovery partly because I was looking for a home in the field of dietetics that resonated with me. I was very suspicious of the American Dietetic Association and the political climate they're in, where they were getting their funding, everything like that. And when I saw eating disorder dietitians talk about food and food politics and their relationship to that governing body, I was like, okay, I could hang out with these people. And then as I started working in the eating disorder field, I realized the struggles that the people I was helping with are also struggles that I had as well. And so we kind of it was an awakening there, and did my own healing alongside a lot of my clients, separately, obviously. And then eventually I came upon internal family systems therapy through sexual empowerment work that I did in my own healing with my body. And the coach that I worked with there was trained in IFS. And that was just so life-changing. I and it felt aligned with the work that I did professionally. And so I sought training for level 1. And here I am today. Was that everything? Okay, great. And I will pass it to Enos.
Okay, well, let's see. Some of you have heard that I've been a nurse for 800 years, not exactly, but feels close. And in 1984 in Kansas City, Missouri, the hospital that I worked at opened the first eating disorders inpatient unit that I'm aware of anywhere in our region. And I heard about it, that they were seeking staff who might want to work there. And because of my own lived experience with, again, I won't even begin to try to count all the reasons that intrigued me and that I threw my hat in. And so we were sent out to Orange County, California, the whole team that was hired and trained there. And so that was where I really got my foot into this whole world of taking care of amazing individuals who were just, I don't know, they brought so much joy into my life to see people work and grow and heal. And that's how I got my foot in the door. Then in 2002, I was invited to come to St. Louis to explore the possibility of working with a residential treatment center here. And that turned out to be just a great timely thing for me. My mom had passed away a year before that, and I had been her caretaker. And so prior to that, without my mom having died, I would never have even taken that leap. But anyway, got here in 2002, and lo and behold, Dr. Dick Schwartz came and did training with the staff and in IFS. And so every bit of my experience for 13 and a half years working at that treatment center was like really enmeshed in the world of IFS and all the ways that, again, as IFS informed, I never have consider myself an IFS clinician. I do have a master's degree in nursing in adult psychiatric and mental health nursing. But anyway, just very much IFS informed, and currently work with people with developmental disabilities. That's kind of my second passion. And I'm really just trembling about things that are happening in this administration that are threatening the very existence of help for them. So it's just been a heavy, heavy time for me. But I have never lost my passion for working with eating disorders. And I think in my own way, I just always a champion for people learning to understand their relationship with food, understand their relationship with their body. So I do that more just on a regular in my daily world. Oh, I'm supposed to pass the baton. Is Dr. Leslie still on?
I don't think she is. I don't think
Okay.
she is. So
Okay.
She
Then
might
I'll
come on.
yeah.
Then I'll pass it on to Jean.
Great. Let's see. I said a lot before in the beginning. I mean, I started out as a psychologist and kind of accidentally, not so accidentally, came into this field where I had my stuff to work out, but didn't know that. All I knew is I kind of wanted to work I liked the idea of working at a treatment center with other women. That felt like it was very feminist oriented. I found the experience I didn't experience that very much in the actual execution of the treatment. But as somebody who I think I'm also maybe not 800 Enos, but 700. And so I kind of came into the field at the time where psychoanalysis, psychodynamic psychotherapy were, prominent. And that was the beginning. Those were the beginning modalities. And as somebody who had a lot of trauma in my past, I experienced firsthand a lot of the sense of, oh, you're just not being compliant. You're too much. My feelings were hard to, the extreme feelings that I had were tough for people to deal with. And, oh, you seem so upset whenever you talk about these things. Maybe you shouldn't, that kind of thing. So I think naturally that didn't work very much, or you're so angry, whatever it was. And, a lot of blame and feeling like somehow I just wasn't getting it right. And I think over time, working with folks with eating disorders, I always had this profound respect for how these behaviors were helping them, got respect for how they had helped me, and then started gravitating towards therapies that were more somatically based. I felt more respectful of the entire person. And then, like I said before, I met I started referring my clients to a treatment center where Enos and Teresa were working that center used IFS as its center modality. And all of a sudden, I saw some of my clients transforming in ways that they were just unbelievably profound and respectful, and it trusted that within them was the resource for healing, and that it wasn't up to me as a clinician to manage it, make it happen, that they had to wait till their next appointment to have access to it, that they had it. So all of that was tremendous. And so I really wanted to learn it, and I did. And then the more that I learned and steeped in IFS, and for those of you who don't know, I'm married to its founder, Dick Schwartz. So I'm really steeped in it. Like, this is like 24/7. But what I started to notice was how many people who had done tons of work in healing were still living with what Teresa has described a lot about, with the symptom recovery, but not real recovery. And not only that, a tremendous amount of bias about who got eating disorders and disordered eating that was actually only astounding to me because of my privilege and my blind spots, because people were like, well, Black women aren't as vulnerable to eating disorders. And I'm like, are you kidding? Like, that's not what I'm seeing. That's not what's, and kind of, again, astounded only because of, what I hadn't had to look at before. And so I felt very much like very committed to doing something about that, and kind of what Erica was speaking to, kind of dedicated to how can we start to shift things so that there's more access in so many ways, both to mental health generally, for people in underrepresented communities, but also in terms of the eating disorder field, which is there's such gross underrepresentation and access. And also, I have a commitment really to looking, along with many, many other people from whom I've been privileged to learn, like everybody here on this panel and others, about like how can we take the IFS model as it was developed originally and make it more culturally sensitive. And so that's really feels like a very important focus of mine currently. And so, and last year when we came to the conference, I was so tired. I was like, I'm not going to this cocktail hour. I'm gonna sleep in, I'm gonna take a nap. And then I was like, oh, I really should go down. And then I went down and I saw the team from Arise, and I was like, oh my God. I was like a total fangirl, because to me, what I had been seeing online was so exciting and I'm, just so exciting to see people who are developing care that is culturally sensitive and accessible and not hierarchical, and, kind of like trusting people to kind of check in with what works for them and have it be community based and accessible. So I'm excited to hear more about all of this, but that's really what I'm on fire about now. And so I'm very happy to be here.
Right, let me unmute myself. Great. All right. So, what we saw in terms of the therapy session that you shared, Jean and Ines, there was a level of vulnerability that we just don't often get to witness. And I'm curious, what made that space feel safe for you? And what advice would you give to clients who are unsure about trying IFS for the first time?
Well, again, I think that I can't help but acknowledge that there was a level of comfortability just because I know Jean in context to my years of work, 13 and a half years straight of work, and being just immersed in the IFS world. And especially having had training straight from Dick, and had, other times where he came and would be a part of our whole therapeutic process. And so I just I think I felt safety from the beginning. And then I'll just have to say again, the way that Jean was able to just organically witness me was, I don't know, I think it made it so much more possible. But for me to, I think I told Jean that I came in feeling a vulnerability, but it was not like about her. It was just vulnerable because I know IFS enough to be feeling vulnerable. So I do know that that was a big part of what made it safe for me. So then what I would extrapolate out of that to anybody else, as I've been trying to speak to the people who are participating here with us, is that take away from that how important it is to, number one, I think we've heard a lot about not making assumptions, but to be willing to create that space to get to know what this person's lived experience has been, and being willing to have the courage to sit and witness it. That is, you must start there. It makes me wonder too, can I ask you a question, Dr. Angela?
Yes.
So having known from meeting you all the way back to 2023, that you are very hesitant about IFS. I think you see it and are in awe of it, but I wonder if anything about watching that session gave you any curiosity about what it might be like for you.
Yes,
To
I
put any
think
pressure
so.
on you to have an answer to that, but it just makes me curious. Um,
I think so. I think there were times where I was like, okay, she's talking that talk in terms of parts and, splitting off and, there were certain parts where I was like, whoa, I don't know if I could go there. And there were other parts where I was like, and I'm not talking about my parts, I'm talking about the parts of the the actual session. There were other parts where I was like, okay, if I had someone that was like Jean that could do that, then that could create that sense of safety. I could see building a relationship with a person like that. But for me, it's like trust has been broken so many times with clinicians that I just don't know how I would approach someone. So my brain would tell me, okay, they have to have so many years. Okay, I'd prefer if they were, if they looked like me. Okay, I'd prefer if it be in person. All of these things are almost impossible with the few of people that are out there that could actually help me. And so that could be another barrier or layer of resistance on my part too. And so I don't know how to undo the harm that's been done to me at the hands of clinicians that were really frustrated with me. I am treatment resistant. I do not take my medicine. I literally started, I don't take Wellibutrin. I will fill the prescription and then I just won't take it. I deal with suicidal ideation, and those things came up when I was on certain medications. And so, it's too much. It's so much that when the provider gets too overwhelmed, then I feel like I am so bad that nobody can help me and I'm triggering the practitioner. So let me just stay on the level with where they're comfortable, because where they get comfortable is they get comfortable when they're like, oh, wow, you have a PhD. You went through all of that and you still did this. And how did you do that? Well, I'm a Christian. Oh, that's great. Let's talk about that more. Yeah, but also don't understand that a lot of my trauma came from Christianity and people that are so-called Christians. So, but I don't talk about that because they just want to hold on to the good parts and just kind of like talk about that. And one even said to me, "You are not a victim." She yelled it at me. She was so angry and frustrated at me. And listening to this session, I'm like, to your session, Enos and Jean, I'm like, well, dang it. Well, maybe a part of me is a victim, and maybe part of me isn't a victim. If this is what IFS does, maybe I just needed to talk about it and not someone not getting like angry at me about, whatever I was, going through at the time. So, yeah, I don't, and so my thing again, the reason I'm here is to advocate, so when someone else like me comes through the door, that you don't like start building up these barriers in their mind and essentially locking the door on them. So I don't think I answered your question. I'm
Yes,
so
you did.
sorry.
Yes,
That
you
is
did.
so
Yes, you
powerful,
did.
Dr. Angela. And it makes me wonder, it brought up, and actually it leads to my next question
Can I
anyway,
ask
like perfect
Dr.
timing because I
Dr.
think,
Taylor, can I ask Angela something? Would you mind?
oh, of course not.
I'm
Yeah,
so sorry.
absolutely.
Angela, if it's something you want me to pause on, please do. But I just want, if it's okay to respond to what you just said, you asked a really important question. You were like, what do I do when there's been so much harm,
Mhm.
when I've been hurt so much? And I would say with the IFS model, we would start there,
Mm.
right? Can we be with the parts who got hurt in oh so many ways? I mean, you just ticked off at least 10 different ways to me that it would make really good sense for you to not actually want to engage in an IFS session or another therapy session. And I think we don't need to speak about you directly, but even what Dr. Taylor was saying about in terms of the ARISE team checking in with all the different parts to get their permission about taking Wellbutrin. There's an IFS psychiatrist, Frank Anderson, who does that with meds, because what he has noticed, and other psychiatrists have too, is that you can give people a medication, but are they going to take it down off their shelf? I know, Dr. Taylor, you're like, yes. Are they going to take it off their shelf? Are they going to get it filled? When they take it, is it actually going to have an impact? And that's because our parts can affect our physiology. And so what I would say is, when you've been harmed so much in the way that you have, and I'm sure you're speaking for so many people, I mean, you're speaking for me. I was treatment resistant. I was a victim, according to certain people, because they didn't know how to treat trauma in the 90s. All they talked about it. And so I was seen as somebody who just couldn't do it right. And I had parts who felt like that. Like I would be getting better if I was just doing this better. And so I think with IFS, I mean, I would love to see you have an experience that felt better for you, where you could try it with somebody who did feel safer to you, so that you could be with somebody who could get curious about, tell me about what your fears are. Tell me what to witness, like we did with Enos, like what happened and all the ways it hurt, and then um, to see if there was any room for parts to be willing to, kind of lay some what we call hope urgenting. Like, if it were possible to do this a different way, would the part of you who's really feeling skeptical and like feels like this is a lost cause, would it be willing to make some room to try this again? Maybe, perhaps, right? But that's what we do. We don't steamroll over it and say like, oh, well, you'll find a better therapist. We really validate you got hurt in these processes, and we want to hear how, that kind of thing. Does that do you, and addressing some of the fears around things like the use of the word parts and what that brings up for people, and how scary that can feel to people who've been taught that that means disintegration rather than relationship, you know? So I don't know how that lands for you, but it's just something I thought I'd offer in terms of what you just shared, because there is so much more potential, I feel, for a better outcome.
Mhm. Yeah, I'd like to sit sit with that if that's okay.
That sounds good to me.
Mhm.
But
But thank you.
And I will
I don't
say
want to cut you
too,
off. Oh, go ahead.
I just want to say to Angela that another thing that I experienced was this sense of safety, first of all. But second was, this whole thing about parts is so amazing, because what happened for me in that session was, inside of me was a whole family of who I am.
Mm.
just really, because you all didn't get like this whole big thing that happened. You just got pieces of it. And but there was, it felt like a family session, like if you went to family therapy or something. It was like a whole, more of an integration than a disintegration. It was this integration going on inside of me that had, I mean, they had trailheads to things we didn't even touch, but it was trailheads to things that I know were directly related to, my own life, things that have happened, why these parts of me actually are existing and working together to try to help me. And in many cases, overworking. So that balance that kind of came in at the end of this conference table and this, all the parts that showed up that day, kind of going, I want to be on a committee to help for some balance. You're too old and I'm too tired, So I don't know. I hope it, in some way, I hope it just creates a possibility and a space inside of you that um, that maybe one day you could experience, um, from the inside as well as from the outside. I'm probably tearful because I'm so sad that nobody ever did tell you. I'm sorry if I harmed you.
Mm-hmm.
It's hard for me to hear that, you've been harmed so much and that you didn't have an amazing Dr. Erica to say, hey, I don't know if I did, but if I did, I'm so sorry.
Mm-hmm.
So, anywho, I'm gonna stop. Oh, you're muted.
I'm muted. I'm talking away. Um, I too feel sad about that, and I'm curious. I want to pass the baton to Joan because, Joan, I know you've also dealt with harm and treatment before. And how did you get to this space of being open to IFS? And what was it, maybe that your clinician demonstrated or something that happened in the room that helped it to feel safe with that kind of approach?
Yeah, I think I've gone to therapy for many years, and when I was first going through eating disorder treatment, very well-intentioned therapist. I still credit her for really doing some incredible work, but there were these assumptions made, or I guess lack of recognition that, in my culture things are different. I think I have a lot of trauma with my family, my parents, and her kind of reaction was, well, just set a boundary. Cut them off. And I was like, that's just not going to work. I'm the eldest daughter of immigrants. I'm translating, I'm doing paperwork for them. It's just not possible. But again, I think I alluded to this earlier. I also grew up in this kind of culture where we just felt like the doctors told you what to do and you listen to the doctor and you don't push back. And it wasn't until I really started, going to a therapist who, and frankly also like a coach who was actually IFS informed, who just started our relationship by saying, like giving me permission and asking me and inviting me to let her know when what she was saying wasn't working, wasn't resonating. And I was like, oh well, if you're telling me to do that, then okay, it's kind of a reverse psychology thing. Like then I got to do it, then I got to follow that, and then push back. But just that asking for permission piece was so profound for me, because I think I typically find myself people pleasing. And so if the therapist says, oh, let's do this, I'll just go there even if I don't feel ready. And so, the asking for permission of, hey, can we ask that part, how it's feeling? Or, can we dive deeper there? Or can we ask this part to, sit aside for a moment? being able to like really kind of just sit with that and make a decision, I think was really, really a key part of feeling safer. And I think that the other big piece was really feeling a lot of times kind of gaslit in traditional treatment and feeling like, oh, well, it's just body image. You should just feel confident about your body and eat. And I, for a long time, I was just like, well, why is this so hard for me? It looks like it's so easy for everyone else. And and it wasn't until really like digging into IFS and doing that parts work and seeing not, these parts, especially the eating disorder part, as not this thing that I had to just repress and keep down, but really as like understanding and having a conversation on what is it trying to tell me? What is it teaching me? And it made me realize like, wow, this part has been protecting me from a lot of racial trauma that I experienced growing up. And it was so healing because it felt like, oh, I understand you now. We're not at odds. I don't need to spend so much energy just keeping you down. We can really work together because we're all on the same team here.
I love that, Joan. We're all on the same team. And I think it sounds like for some people who think about IFS, it's such a different approach when they hear parts work. It feels like, okay, these are different parts. They're not all on the same team. They're like opposing one another. They're fighting. And then it's kind of scary, right? And there are even times when I think people who are going through this work have trauma. For instance, this person, Bianca, was diagnosed with DID. And it's like, okay, is this DID? And for those of you who don't know what DID is, I'm sorry, Dissociative Identity Disorder. Is it DID or is this parts work? And how do we that's why the focus for the team so much was like integrating the parts, because all of the parts are one person. It's not like these different people, but they're all parts of one person just really trying to accomplish the same goal, right? But it's demonstrated and manifested in different ways. So I'm curious, I'm going to maybe throw this one to you, Jean. Like, how do you, for those who are hesitant, I guess, to engage in IFS because they feel like, oh my gosh, this is just going to drive me even more crazy with all these parts. I can't keep up in the language of it all. How would you describe that and distinguish it from something like DID or personality disorder?
When you think of these as these parts of like inner people, like inner personalities, inner children, when you think of or young adults, when you think about, not usually younger, but not always, but when you think of them as relationships and you think about what happens in your actual relationships, it becomes much more organic and a lot less frightening. Like, what teenager likes to be told what to do, right? But a younger child may feel more open to being told what to do. It make the behaviors and the feelings and the experiences make much more sense, right? And then relating to these different parts feels much more organic. Then I think that when, first of all, diagnoses never feel good, do they? Right? This idea of there's been a lot in our culture about dissociative identity, DID, very scary things like Sybil, and right, a lot of stories, a lot of narratives about folks who have different parts of themselves that are not as in connection with each other, that don't know as much about each other. And with IFS, what the IFS model is saying is we all have parts that vary in terms of the degree to which they are in connection with each other and with our core self. And and it's a real continuum. And when somebody has what has been diagnosed, when somebody's diagnosed traditionally with DID, with dissociative identity disorder, it's more of a sense that because of all the trauma, it was safer for the parts are not in connection with the core wisdom, and it wasn't safe for that when they were younger. There wasn't an awareness that there was a self, and that the parts are more or less existing in their own little orbits, doing the best that they can to survive, and that what we can do is help them over time get to trust that there is a core self. And again, one of the most empowering things about IFS is that I'm not giving somebody self, they have it within them. It is a resource they're born with, that because of various traumas and injuries, parts became disconnected from them, and parts were forced into these extreme roles. And then, you think about it each in their extreme role, one part isn't aware of what they usually, oftentimes, of what the other part is doing. Like the part who's restricting doesn't really want to know about it, knows about the binging part, but it's like it doesn't value it. It doesn't think it's doing anything important. Over time, what happens is, with the help of the self of the therapist, so there is a help there, kind of brings the client's self online more and helps the parts actually trust the self, kind of get more of a sense of the other parts. And so there's much and much more connection, less disconnection between the different parts. But I think there's a lot of scary narratives about dissociation as opposed to, dissociative parts are very protective, right? The ones that get us to not focus on the feelings, get away from the feelings, be a very helpful way of surviving the intolerable. And especially when people learn that, they settle more and they become more curious. And that's the beginning, the more of that curiosity and exploration, more access to self energy. And usually it's in severe cases, it starts with the self energy of the therapist. And I think so for folks that are really afraid of coming into therapy, oftentimes it's with the help of somebody who can stay self-led, who isn't going to be freaked out because somebody has a part who seems extreme, binges a lot, or gets suicidal, or can dissociate, and instead gets curious about, so that part is trying to help you out. Let me learn a little bit more about it. So I know others know about IFS. I don't want to take up all that time and space. Did I answer enough for, okay?
Yes, absolutely.
And I don't know, Mimosa, if you wanted to add something, or Ines, or from your experience.
I don't. I think that was a very good description of
Okay.
and differentiation even between a DID diagnosis and parts that are just innately who we are, a combination of who we are.
Yeah.
I'm curious for those of you who are clinicians. So this goes for you too, Mimosa and Ines and Jean. How do you sit with that discomfort of the parts, and especially when, I think like in the case that we saw today, there was a lot brought. I mean, that was really intense for me. I've felt it because I've been. I was like, oh wow, you're releasing some stuff for me too, and that's that I've been holding. I guess one part of me has been like, girl, we're gonna simmer that down a little bit. As a protective mode, and I felt kind of like activated. And I think sometimes people may be afraid to really be open and honest. And Dr. Angela mentioned this, right? Like, I want to do what's appropriate for that. I don't want to set them off too much. I don't want to, disrupt what's happening with the therapist. They may not be ready for all of this, right? So, and sometimes we feel like, okay, especially, I'll just share a personal experience. I remember I saw a white therapist at one point, and I was bringing up some racial things that were happening in my work environment, and it was almost like a deer with the headlights on. I was like, "Oh, okay, she was not ready for this conversation." So I find myself stepping in trying to protect her, and that's what we do as clinicians anyways, right? We're like the worst patients. But anyways, how do we sit with that discomfort? And for those who are watching who are like, yeah, I don't know how I would have been able to hold that space for Ines talking about, you know, not feeling safe and feeling like she's in danger. I mean, these are like serious statements. Like, I'm just curious how some of you as clinicians, and maybe we could start with you, Mimosa, how do you sit with that discomfort? I think the dietitians, you all get it, especially, right? Because so how do you navigate that and create that space and kind of sit with the discomfort, even knowing that, the systems of oppression that may be brought up, like you've benefited from, living in a body, as you mentioned, where there's some privilege here. It's like, yeah, I've benefited from these systems of oppression that have actually harmed you. How do you hold that space?
Yeah. Oh,
No, good, I'm
uh,
sorry.
yeah, thanks so much, Dr. Erica. And I love the question. I also have a part that's like, oh, I want to speak to how I got from level 1 to like sitting on this panel with y'all. Is that okay if I just speak to that before I answer the question? Okay. Yeah. After completing my level 1 training and developing my understanding of eating disorders and oppression, I've come to really see eating disorders as an effective coping for living in our oppressive society. And so we can't treat eating disorders, in my belief, without addressing systems of oppression. And when the Internal Family Systems Eating Disorder Conference was offered last year, part of my dismantling of oppressive systems is being really intentional about where I invest my energy and my money. And someone sent this conference to me, and first thing I did was see who was presenting. And the y'all being on the panel last year was what made me go to this conference last year. And I emailed Teresa, and I actually reached out to Dr. Angela and Ines beforehand. And I was like, I'm so excited to see you. Like, I was fangirling over you guys too. And I sat next to your table, and I'm so glad we got to meet at that conference. And that's why I'm here sitting with these incredible people today, is that relationship building. So back to your question about how do we sit with that discomfort? And I will admit, like, sometimes, like, yeah, my parts get fired up. I'm thinking about one client in particular who, like, I really felt a part get activated on their behalf, and really want to get up and fight for them. And I asked them if I could speak for that part that's like wanting to get up and fight for them. And they said yes, and I did it. And then afterward, after the session, I kind of sat with it, and I was like, that part kind of took it over. Took over the session, took over the experience. Like, my part took up a lot of space. And so at the next session with that person, I asked if I could offer an apology for the the way I handled that. And they said yes. And so I offered that apology, and they were kind of surprised. But I would just want to share that as, like, sometimes it's hard to, like, notice the part, ask it to step back, stay in self energy, and, like, not let it take up space. And luckily, because of the language of the IFS, and the practice I have with my parts, I feel like I can speak for them and also apologize when harm has been done. And through that practice, like, just like anything, it gets easier for me to notice the part, ask it to step back, and then supervision is a really helpful place too, where you can kind of practice with people, ask them to bring in a oppressive experience that they've navigated, and practice just being with that, asking your parts to step back so that you're not doing all of your practice with your clients. So that's my answer to that one.
I love that, Mimosa. And I just want to highlight what Chantal said. A provider apologizing and accepting accountability for missteps and misunderstandings can be so powerful for healing a patient's relationship with the medical system. And, for you to have that humility, but even before that, the self-awareness, right? And the reflection and then the humility to say, oh, that was a misstep, and to bring that and to offer that, I think is really amazing. And I just wonder what would happen if we were able to do
Mhm.
that more often, right? When we realize like we are not the know-it-all. I like to feel like I am the know-it-all, but I'm not the know-it-all. You are the know-it-all. So how can we take that ownership? And it sounds like you do that as well. So yeah, thank you for sharing that.
I would like Angela put in the chat a question that was, I think, Mimosa, you just responded to. Would you mind if I respond to it also with the how do I prepare myself as a practitioner to hear your clients express anger or grief towards oppressive systems you may be seen as benefiting from without taking it personally?
Mhm.
Because I think relevant to this panel, is it okay with everybody? I just want to check in with my panelists. Okay. Um, I feel like it is personal to the extent that the four goals of IFS, and I feel like this is something that feels so important to me, which is one of them is as we become self-led, we become more clear about the importance of bringing self-leadership to heal external systems. And I feel like it's it feels when I was doing this, Enos volunteered to do this work, and I thought um, I had all kinds of parts coming up about like, who am I to do this work? Who am I to sit with Enos right now and her experience? Um, what will people think? Will I get it right? Will I do enough? Um, what do I know? What do I know about her pain? You know what I mean? Had so many parts that were coming up, and really, but who are you to do this work? Like, that you've had experienced so much privilege, innumerable kind of things, and how can you be of help to her? And one of the things I kept doing was checking in with these parts and like seeing what they needed to give me some room to get curious about what their real fears were, and also to get clear about what my motives were, about why was I interested in doing this work. And for me, what felt so important is for us to be two people with two very different lived experiences. I think we I can't remember, I'm sorry now, who said it before, though. And sometimes when we think about um, what would be ideal, would it be to have somebody who is, and Erica, you brought out, like, you can be a Black woman who doesn't know another Black woman's experience, of course, but we have these ideas about if my lived experience matches more, or Enos and I talked about if I know the IFS model super well, like that's going to ensure good care, and it doesn't always. And I think the elements of this work that do for me are this real commitment to being curious about this person across from me and what they've experienced, and a real compassion and care and a clarity about the harm that continues to occur in the world, and not lapsing into shame or blame that I've benefited, but more a sense of like, I have benefited and I have a responsibility um, as a human being to do the things that will help things shift. Again, what Dr. Leslie was saying, like little each act by act, right? That we can do this. And so once I got clear with my parts about a couple things, you're going to make mistakes because that's how you learn. You're going to learn. You're going to have the benefit, the privilege of learning from this human being who is going to be able to share with you, and also you're doing what you can, the best you can, to contribute some self energy. The one thing I was concerned about that I had to keep checking in with, and we saw it today, was this is not it's occurring in front of us, this continued culture of harm and danger. And so when Enos consented to do the session in October, really, this is what we are we in more April. We're in April, and it's still a matter of like, I'm imagining like you don't know what you're consenting to, right? Because the conditions are still in existence. And so, again, the best I can do is, instead of getting into a binary of did I get it right or wrong, is keep checking in with, how is this for you? How is this for you? Is there anything you need from me? And, you know, doing my own work, like Mimosa is saying, doing my own work to learn as much as possible. And like I said, I really do feel like I've learned from everybody on this panel in the time that in small things and bigger comments that really will help me become a better person, but a better practitioner. And that for me is where the worth is. But I prepare by saying, can you all give me space so I can be as curious as possible? Mhm.
And then several times you literally ask me if it's okay this or if it's okay that.
Right, right,
Um, and even if you'd ask me that, then you say, because you might, as I would be going there internally, the part you can't see. That's one thing
that's right,
about IFS is
that's
that
right,
you're you're sitting there, but you're not privy to what is actually going on.
that's right,
Either what I'm actually seeing or what I'm experiencing, feeling, what's coming up. But
that's right,
then if you would ask me or something, is it okay if I check in about this or that? And as I was checking in about that, you would sometimes say, because you get to decide that, something to that
right,
effect. You'd be like, you get to decide if it's okay.
right,
So,
right. And because I was important to me that I was concerned you might have parts you might want to please me, right?
mhm.
Because we're talking about history of like people like pleasers, right? Parts that are easier to deal with and not the ones that are resistant or angry or don't want to go there or whatever. And there are always some parts in the background who, we can imagine, not for me, there are always different parts saying different things. I have to check in with my own parts. I mean, you know,
Yeah.
thank you for letting me share that. Mhm.
Thank you for sharing. Thank you for sharing. Well, I want to be mindful of the time. We have 2 minutes. So, this is probably a good place for us to just go around and see if there are any final thoughts that you're having.
I wanted to make a final comment probably. I had promised in the chat that I would save comments from participants in our Google Docs, and I did, and I have their names next to your panels and what you presented. So if anyone wants, any of the presenters today to reach back out to you and address those, there just wasn't enough time to address each one. Please direct message me your contact information and I'll put that in a Google Doc that we have that's shared and they will be able to address that and get back with you. That's if that's okay with you all. But I just wanted them to know that I did what I promised and
And I
that
tried
their
to go
questions and
through
comments were hers. I know it's a lot.
I tried to go through and address some of the questions that were in there, but there are a lot of questions. Wonderful. Thank you. Thank you, Dr. Angela.
In
Any
these last few
final
seconds,
comments?
I want to really thank Jean over and over again for just this amazing experience. And then I want to speak to this panel and thank you all as well for, again, I feel so seen, I feel so witnessed by all of you, and including all the participants that chose this session. Um, I'm just so grateful that you guys are
Mhm.
there, and I am imagining processing this in so many of your own ways.
Mhm.
I actually have made myself recognize that there may be people that came to this session who may be a part of the people that see the world differently than me. And I'm really allowing myself to be very okay with that because there's there's definitely in the core of me this thing that knows if you really do experience the world or see the world that differently, like where you would question my own value or whatever you might say, that something brought you there to that place.
Mhm.
And so I can honor that I don't have your lived experience either.
Mhm.
So, but I do thank you all for uh, being here.
Yeah. Thank you all. Well, I think that might be a good place for us to conclude. So thank you all for being here. Thank you to Teresa and Nancy for hosting us for this panel round 2 years in a row. So thank you for giving us this space and this venue to really share our experiences and really iron sharpens iron, right? So that's
Mhm.
really why we're all here at the end of the day. So thank you for your
Love
time.
that.
been wonderful. I think there is more to come in terms, maybe Nancy, I could pass the baton to you. If Nancy's here, she might be gone, but I think there is like, oh, yeah, Nancy, I think she is here. Nancy, any last final words about next steps? It's like a happy hour or something, right?
Mm-hmm. And I can send her a text. I think that she had said that she was going to keep this up, but on low and was jumping on another one. So
Okay.
let me see, because I know it does say closing and next steps, but I don't know what that means.
Okay.
Let me get with her real quick.
Okay.
I added a summary and a journal prompts for anyone that wanted to kind of go through them and just to
Wow.
debrief. Yeah, because I knew that the ending was a little bit different, and I wasn't exactly sure if Nancy was going to be here. So it's just
Oh,
a summary of the day and journal prompts, such as, in fact, I can actually go down and put them, what parts of yourself showed up as you listened to the speakers and the case studies. So just to kind of at the end of the day, something for people to think about. And then I don't know what,
Great.
I think she kind of summarized at the beginning, and that's what she said. There was no way for us to come back to come together as a group. So we were actually going to have to close out here. I
Okay.
remember her
these
saying that.
journal prompts are amazing. Please take a
Yeah.
look at this document that Dr. Angela created. And I
Right.
just have to thank Dr. Angela so much because she
So
really
much.
was like behind the scenes helping to keep us organized. So thank you, Dr. Angela.